Namaste and good evening, everyone. I welcome you all for today's webinar on clinical update on common cancer. With immense pleasure, I would like to invite Dr. Chitresh Agarwal. He is a senior consultant, medical oncology and hemato-oncology at Paras Hospital, Panchkula, and Agarwal Cancer Care and Diagnostic Center, Panchkula, for the welcome and introductory note. It's over to you, sir.
Thank you for the introduction. I welcome you all to the clinical updates on common cancers that we are holding a virtual meeting on 3rd and 4th of July. I thank the support and the technical support being provided by the Horizon team. And I thank you and I welcome all the participants, the panel discussants, the moderators, the speakers to this virtual conference. So without, wasting much time, I would move on to the first session, that is on breast cancer. So this is a session which will be sponsored by Roche, and for this session, the topic is impact of subcutaneous dual HER2 blockade on patients with HER2 positive breast cancer. And we have with us very esteemed speaker, Dr. Sachin Gupta, sir, who is Director, Medical Oncology and Hemato-Oncology at Max Super Specialty Hospital, Mohali. So I would request Dr. Sachin, sir, to please join in and start his talk. That is the first talk of this virtual meet. Thank you.
Thank you, Dr. Chitresh. So for
Thank you, sir,
organizing
and welcome.
this, phone calls shuru evening. Let me just share my screen. ओके ठीक है अभी स्लाइड शो मोड पे आ गए
Yes, sir.
You can
It's
see that
visible
and you
Yes,
can hear.
yes, they are visible.
Okay. All right. So we'll be discussing the new treatment options in HER2 positive early breast cancer, focusing on the use of Phesgo, basically. So we know that achieving a pathological CR with neoadjuvant chemotherapy, this is resulting in longer survival benefit than having the residual disease. So this is the CT Neo breast cancer meta-analysis and real-world evidence also. So we can see the difference between EFS, DFS and the OS if the patient is achieving pathological CR versus having a residual disease with a good robust HR of 0.48, 0.36. And on the right side, if we look at the real-world evidence also, so this was there in Lancet few years back. So this suggests that pathological CR does make good clinical sense to achieve, and it is making a difference in the outcome. And so neoadjuvant treatment with pertuzumab and trastuzumab plus chemotherapies results in higher pathological CR rates versus only trastuzumab and chemotherapy. So this slide captures a lot of trials in this space. And if we see on the left-hand side, NOAA, HANA, Neosphere, then Trifina, JIPA, Octo, Septo, so all these trials. And in the low down in the slide, you can see the regimens and the number of patients and the phase of the study for these studies, and the duration of anti-HER2 therapy. So we can see the pathological CR rates are higher when we are using pertuzumab and trastuzumab combination. So which is obvious. This is a tune of more than 60% most of the times. So the patients receiving neoadjuvant dual anti-HER2, they have improved EFS compared with those treated with only neoadjuvant trastuzumab. And so this is from HANA, Neosphere, Trifina, and Christine. So all these studies again establish the same fact that the event-free survival rate with pathological CR by treatment modality. So this makes, so the difference is good, and it makes again good sense for using in our patients. So this is a pooled analysis, and again, this is summarization of the similar data that patients with event-free survival, the EFS event percent. So if we follow trastuzumab with trastuzumab, then what is the EFS? Then patient without this and pathological CR, if it happens, then what happens? So all these studies suggest again that there is good, regardless of pathological CR status, reduction in EFS event risk was greater in patients where dual anti-HER2 was given. So this is Burnett study, the cardiac safety study of neoadjuvant dual anti-HER2 and chemotherapy, followed by adjuvant pertuzumab and trastuzumab. And so the cohort A, this was anthracycline AC regimen was there, and cohort B, FEC, followed by DOSI and this. And the NYHA class 3 for CHF was about 1.5 and 1%. So there were similar adverse events in both the cohorts, and 5-year EFS rates were similar across both the cohorts. And patient pathological CR had better EFS rates compared with patients who had, again, residual disease. So if you look at this graph on the right side top, the 5-year EFS rate in cohort A, 91, and here it is 89. And in the lower down, so we have AC followed by TPH and dose dense AC followed by TPH with residual disease. So both the residual disease curves are going down, whereas the pathological CR curves are on the top. And so this is final analysis of phase 3 Peony trial and efficacy, safety, tolerability of pertuzumab, trastuzumab, and docetaxel for patients with early or locally advanced HER2 positive CA breast. And so here the diarrhea was seen to be the most important side effects, and EFS, DFS, and OS were supportive of total pathological CR and suggested a clinically meaningful improvement with the dual HER2 therapy compared with placebo plus trastuzumab. So the hazard ratio here is 0.53. So this PLA is placebo, pertuzumab, trastuzumab, dosi versus placebo, trastuzumab, and docetaxel. The 3-year event-free rate 89 versus 79, 5-year 85 versus 73. DFS is hazard ratio 0.52. And again, there is good difference of, so nearly 10% difference is there in the DFS. And if we look at OS, the difference is about 6% 3 years and about 4% at 5 years. So showing OS difference as well. So now NCCN guidelines are including dual HER2 blockade for many years now. And TCHP is the commonly used regimen for fitter younger patients. And so if there is no residual disease after pre-op therapy or no pre-op therapy, then we have to complete 1 year of HER2 targeted therapy with combination. And if there is residual disease, then of course we shift to TDM1. And suppose we have to discontinue TDM1 due to toxicity, we can go ahead with trastuzumab, pertuzumab to complete 1 year of therapy. And especially if there is node positive at initial staging, we tend to use trastuzumab plus pertuzumab. And similarly, any node positive patient should receive adjuvant chemotherapy with trastuzumab plus pertuzumab. And so we are following this for most of our patients wherever finances are allowing us to go ahead. And this is for, so the previous one was for hormone receptor positive, and this is for hormone receptor negative HER2 positive. Again, wherever node positive, we should use this combination. And for recurrent unresectable or stage 4 metastatic disease also, and so wherever HER2 positive, we can use this combination in the first line without carboplatin here. So now Pertuzumab, trastuzumab, and hyaluronidase injection for subcutaneous use may be substituted anywhere that the combination of IV pertuzumab and IV trastuzumab are given. So now we'll see some other guidelines also. So this is ESMO clinical practice guidelines, and here again, if we look for small size disease, we do surgery and local regional radiation. So for T1, only trastuzumab may suffice. Anything more than T2, trastuzumab, and 1 year we just complete this. So for node positive, complete. So this here we this pertuzumab is advised here. And if the patient has upfront more than clinically T2 and plus, then we can go ahead with neoadjuvant dual anti-HER2. So now we know that process of receiving IV therapy, this places significant burden, and so these patients have a lot of infusion visits to the hospital, and so IV infusions do cause some logistical issues. So a lot of time is taken, and the longer stay in hospital, and the pain and discomfort of infusion. So all these things may have some emotional impact, and some studies have shown that there is emotional impact of exposure to other cancer patients also in the infusion ward. And so this also depends upon the stage of the patients during their infusion journey and their own circumstances. And so Roche has came up with this combination where the drug can be administered subcutaneously. And so since IV infusions can be lengthy, and so we have some options here. So this is the study which captures the anxiety, frustration, guilt, isolation. So all these issues the patient can face, leading to depression, and so which adds to morbidity and quality of life. So we know that IV infusions take each infusion take about 60 minutes plus the time to prepare and the time to administer and the follow-up time to discharge. And also we need indwelling catheters. These patients may have PICC lines or ports for longer duration of treatment, and the challenge to access IV lines. So now Phesgo contains fixed dose of pertuzumab and trastuzumab and is administered subcutaneously. So this has recombinant human hyaluronidase enzyme to allow higher volumes of drug to be given as the subcutaneous route. So now there are two studies with this use, Federica and Francesca. So the Federica study demonstrated non-inferiority of cycle 7, that is pre-dose cycle 8 pertuzumab serum trough levels, and as compared to the IV levels achieved. So the Phesgo, so this TPCR, these levels were almost identical between the IV use as well as compared to the subcutaneous routes, and well tolerated. And the other study, it was seen that 85% of patients are preferring this subcutaneous drug over IV infusions, and majority of patients who switched, they said their injections are saving time. And so healthcare professionals are also feeling that there is saving of time and resources for preparation and treatment. And the safety profile is consistent, and there are no new safety signals observed when we switch from IV to subcutaneous route. And so the IDFS and OS rates were also similar. So there is, and the most common AEs were comparable within Phesgo and IV arms. And again, we see diarrhea. Injection site reactions are, of course, more with subcutaneous use, but which are manageable and tolerable. And if we see the rest of the side effects, there was not much of difference, but there were more myalgia, more rash, pain in extremities, headache, bone pain, these were more seen with the IV route. So this slide shows that irrespective of the body weight quartile, adverse events were similar in both the treatment arms, in spite of the usage of fixed dose combination. And 93% of patients who preferred Phesgo had a very strong or fairly strong preference to continue with usage of Phesgo. So the compliance was pretty good. And so the main reason for preferring subcutaneous administration was the less time in clinic and feeling more comfortable during administration. And majority of healthcare professionals felt that switching from IV to subcutaneous injections would save time and resources. And perceptions of that there is less drug wastage, reduced staff time associated with preparation and procedures and administration, less time from start of preparation to finish the administration, more convenience for the patient. So all these reasons, healthcare professionals also feel that this is a better way of doing things. And 66% of patients felt that restricted when receiving IV treatments versus 27% when receiving Phesgo. So this is another benefit. And if we see the cost effectiveness of this treatment, so this is equally good. And so whether we use the subcutaneous way, rather this becomes more cost effective in our setting. So so this is Western data, but for our country also. And so with the advent of generics, we'll have to see how things change and what is the cost. But so far, the cost of using subcutaneous actually comes out to be better as compared to the combination, IV combination. So to conclude, neoadjuvant treatment with the fixed dose combination and followed by adjuvant continuation or shifting to TDM1 is cost-effective strategy. And so adjuvant continuation of this dominates all strategies that do not contain pertuzumab, as well as strategies in which IV pertuzumab therapy is continued. And so this is the graph which shows the cost effectiveness acceptability curve. And we have been using this in clinic for quite some time now and feel quite comfortable. The staff also feels quite comfortable using this drug. I think that's what I have in the presentation as of now. If we have
Thank
any
you.
points
Thank you,
to
Dr.
discuss,
Sachin.
you can let me know here.
Yeah. So, how is your experience in a clinical practice with Phesgo, and how many of your patients who actually go up for subcutaneous route rather than the IV route?
So I am trying this for majority of my patients. I think since the time this has been launched, I think most of my patients have used the subcutaneous, barring one patient who is continuing on, let's say, generic trastuzumab, and now because she is now too much, let's say, the faith is on those drugs IV thing, the patient is not willing to change, but rest of the patients are on subcutaneous route only.
And what is your experience with the local site reactions? Do your patients experience these reactions commonly or not?
So not reaction, but sometimes they do feel some heaviness and pain. This is what I have, and I've also myself administered some of the times, and apart from the staff doing it. So I feel there are hardly any reactions. And if there are, they're very minor and very transient. Not anything, I have not faced a significant reaction so far.
Correct. Thank you, sir. Thank you for the input. And thank you for joining the meeting. Thanks a lot. So moving on to the next topic, that is the role of trastuzumab deruxtecan in HER2 expressing tumors. And the talk would be delivered by Dr. Ritu Dave. She is a consultant medical oncologist at Pune. And I welcome Dr. Ritu and I request her to please give her talk.
Thank you so much, sir, for giving me this opportunity. A very good evening, everyone. So I'll just share my screen. Is my screen visible?
Yes, ma'am.
Yes,
Please
it is.
make it full screen.
Right. So my talk is on role of trastuzumab deruxtecan in HER2 expressing tumors. The agenda of my talk is TDXD in the management of HER2 positive metastatic breast cancer, HER2 low and HER2 ultra low, and its clinical implications. So let's look at the molecule to begin with. TDXD is basically an antibody drug conjugate, and it is made of three components. It's basically a humanized anti-HER2 monoclonal antibody with the same amino acid sequence as trastuzumab, and it is covalently linked to the topoisomerase 1 inhibitor, which is the payload, via a tetrapeptide-based cleavable linker. Now, if we were to compare it with trastuzumab emtansine, basically TDXD has a high drug to antibody ratio, which is 8 versus 4 in TDM1. The payload has a short systemic half-life, and also it is a tumor selective cleavable linker. Plus, the most important thing is it has a bystander anti-tumor effect, and we'll see what that is. So if you look at the mechanism of action of TDXD, TDXD basically binds to the HER2 receptor on the cell. It is internalized. The linker is cleaved and it releases the payload, that is the topoisomerase 1 inhibitor, into the cell. And the topoisomerase 1 inhibitor enters the nucleus and causes the cell lysis. What happens in the bystander effect is basically it is a membrane permeable payload, which also has a tumor cell or cell lysis effect on the neighboring cells, irrespective of their HER2 expression. So this all began with Destiny Breast 01, which was a phase 2 single arm study, wherein all HER2 expressing metastatic breast cancer patients post taxane, trastuzumab, post TDM1 were enrolled, and they looked at the PFS and the overall survival in this particular category. So if you look at the median PFS, it was 16.4 months, and the overall survival was not reached. Excuse me. TDXD basically demonstrated response to therapy in 61% pre-treated population with HER2 positive metastatic breast cancer. Coming to Destiny Breast 02, which was a randomized phase 3 multi-center study, it basically looked at the role of TDXD in the second line setting. So here we had patients with HER2 positive unresectable metastatic breast cancer, and they were also previously treated with TDM1. So excuse me for saying it was in the second line, it was in the third line setting. The patients were stratified on the basis of hormone receptor status, prior treatment with pertuzumab, and history of visceral disease. Patients were randomized in 2:1 between TDXD and the treatment of physician's choice, the primary endpoint being PFS and the secondary endpoint being OS. If we look at the PFS, it was in the TDXD arm, it was a good 17 months versus almost, excuse me, yeah. It was a good 17 months versus 7 months in the treatment of physician's choice, and with a hazard ratio of 0.35. If we look at the overall survival in the TDXD arm, it was 39 months versus 26 months in the comparator arm. Moving on to the Destiny Breast 03, here TDXD was basically the efficacy was looked at in the second line setting. So here we had patients with unresectable or metastatic HER2 positive breast cancer, and they were previously only treated with trastuzumab and taxane. Patients were stratified by hormone receptor status, prior treatment with pertuzumab, and history of visceral disease. Patients are randomized in 1:1 fashion between TDXD and TDM1, the primary endpoint being PFS and the key secondary endpoint being OS. If we look at the updated analysis, The median PFS in the T-DXd arm was a good 28 months versus 6.8 months in the TDM1 arm, which basically shows us that the median PFS was 4 times longer in the T-DXd arm compared with TDM1. If we look at the key secondary endpoint, it was not reached across both the arms. However, 77% patients were alive at 24 months and versus 70% patients in the TDM1 arm. So with a hazard ratio of 0.64, I'm unable to move the slides.
So can the Horizon team please upload the slides and do it for her?
Yes, sir. Yes, sir.
Yeah. Okay. I think I can continue. So if we look at the key subgroups of interest, basically by age and the presence or absence of brain metastasis, this was a age-specific pooled analysis across the Destiny Breast O1, O2, and O3 trials. Patients were stratified according to the age less than 65 years versus 65 years and above. So if we look at the median progression-free survival across the trials, across these age groups, we see that the efficacy in patients aged more than 65 or less than 65 years treated with T-DXd was generally similar across all the trials. However, no formal comparison was made. But if we do look at the drug-related interstitial lung disease or pneumonitis, the incidence of this particular side effect, what we can notice is in the patients aged more than 65 years, the incidence was 17% in that particular age group versus 11% in less than 65 years of age. So basically, the incidence of pneumonitis was higher in patients with 65 years or above and across all these trials. And also the other side effects were comparatively higher in the 65 plus age group, which means we should be cautious when we are using in this particular age group. If we look at the pooled brain metastasis analysis, or rather the response of T-DXd in patients with brain mets, if we look at patients who had treated or stable brain metastasis at enrollment, we see a median PFS of 12.3 months in the T-DXd arm versus 8.7 months in the comparator arm. And if we look at the untreated or the active brain metastasis subgroup, the median PFS in the T-DXd arm was 18.5 months versus 4 months in the comparator arm, which basically shows that there was a trend towards prolonged CNS PFS over comparator, and with a noticeably greater advantage for patients with untreated or active brain metastasis. So this is basically a waterfall plot showing that the percentage change from baseline in sum of diameters of brain tumors. So if we look at the T-DXd arm, the kind of shrinkage in the brain metastasis is more prominent versus the comparator arm. These were so Tuxedo was a phase 2 trial. And this looked at newly diagnosed patients, newly diagnosed metastatic breast cancer patients with brain mets or progressive disease after prior treatment. And all patients had received either trastuzumab, taxane, or even TDM1 was allowed. In this particular study, we noticed an intracranial response of a good 73% in the T-DXd patients receiving T-DXd. Also, a retrospective review of patients with HER2 positive metastatic breast cancer with brain mets or leptomeningeal disease. This is a waterfall plot showing that even in patients with leptomeningeal disease, we had a significant intracranial response. Coming to redefining HER2 as a therapeutic biomarker, basically defining HER2 low and HER2 ultra low and its clinical implications in practice now. So if we look at how we define HER2 low breast cancer these days, so HER2 low is basically HER2 IHC score of 1 plus or HER2 IHC score of 2 plus and FISH negative. This particular subgroup is called the HER2 low subgroup, and the incidence of HER2 low is approximately 43% in the non-metastatic setting and nearly 55% in the metastatic setting. Also, if we were to look at the incidence in the hormone receptor subgroup, it is higher. It's almost 65% compared to 37% in the TNBC subgroup. Coming to the challenges for interpreting HER2 low breast cancers, it's one is we do not have a formally established definition of HER2 low. There still is a lack of awareness of the HER2 low classification. Then there are these issues of tumor quality, the logistic issues wherein the time from biopsy to fixation. Also the intratumoral heterogeneity which affects the reporting. Also IHC being a subjective analysis. These are a couple of challenges that we face while interpreting the HER2 low or rather defining and reporting breast cancers as HER2 low. This was Destiny Breast 04 was a game changer. This was basically a multi-center phase 3 study which enrolled HER2 low breast cancers, metastatic breast cancers, treated with 1 or 2 prior lines of chemotherapy, and it also included a majority of hormone receptor positive disease which was considered endocrine refractory or which had progressed on endocrine therapy. So the stratification factors here were the HER2 status IHC 1 plus versus IHC 2 and FISH negative, 1 or 2 prior lines of chemotherapy, hormone receptor positive versus hormone receptor negative subgroup. So these patients were randomized in 2:1 fashion between TDXT and the treatment of physician's choice. The primary endpoint being the PFS in the hormone receptor positive subgroup, and the key secondary endpoints being the PFS across all patients, which also included the hormone receptor negative subgroup, and OS also across all patients. So if we look at the efficacy here, the median PFS in the hormone receptor positive subgroup was 10 months versus 5.4 months in the treatment of physician choice, with a hazard ratio of 0.51. So which was similar to what we saw in the all patients subgroup, which basically had HR positive and HR negative, all patients. So the hazard ratio there also is 0.5, which means a good 50% reduction in the risk of progression or risk of death. If we look at the updated progression-free survival, the primary in the hormone receptor positive cohort, the median PFS was 9.6 months by primary analysis, and in the updated analysis also it was similar with a hazard ratio of 0.37. And if we look at the all patients group, it was also similar. The primary analysis and the updated analysis median PFS was also similar. If we also look at the updated overall survival, in the TDXT arm, it was 23 months versus 17 months in the comparator arm. And which means that in the hormone receptor positive or the all patients group, median OS was consistent with results from the primary analysis. And it showed a 31% reduction in the risk of deaths for patients receiving TDXT. If we look at the results from this particular trial, basically efficacy in the HR negative subgroup, also we see some benefit, although not as much as that we've seen in the HR positive. But yes, even here we have a median PFS of 8.5 months in the TDXT arm, with a hazard ratio of 0.46. and a median OS of 18.2 months with a hazard ratio of 0.48. If we look at the updated adverse events, basically we look at the ILD or the pneumonitis, and we look at the left ventricular dysfunction, which was basically we do not see much of grade 4, grade 5 ILD here. Majority of it was grade 1 or grade 2. Even when we look at the left ventricular dysfunction, it was as expected, not very significantly high. If we look at the activity of TDXT according to the HER2 IHC levels, that is whether it was HER2 IHC1 or IHC2, we see that there was no differences in the ORR across these subgroups, or even in the PFS, there was no difference noted. If we look at the subset analysis here from the Destiny Breast 04 trial, we see that the
Dr.
efficacy...
Ritu, I would request you to please conclude. Your time is getting over. So
Sure,
the last 1 minute.
yes. So basically the efficacy was noted across all subgroups, irrespective of the prior CDK4/6 inhibitor or the disease burden. If we move on to, so just a brief idea about the Destiny Breast 06 trial, wherein the HER2 ultra-low spectrum was included, and they looked at the role of TDXT versus the treatment of physician's choice in the ultra-low subgroup also. Just a little bit on the management of interstitial lung disease induced by TDXT. So here we ask for HRCT scans at least every 12 weeks, if not every 6 to 9 weeks. Patients who already have respiratory symptoms, we try to take scans earlier. In case we have a grade 1 ILD that is noted on the scan, we start with low-dose steroids and we hold till we have resolution of that ILD. In case of grade 2, we permanently discontinue TDXT. To summarize, HER2 basically is a dynamic marker showing intra and intertumoral heterogeneity. Proportion of HER2 low is higher in HR positive subgroup. Also, Destiny Breast 04 significantly showed better PFS and OS benefits in patients with HER2 low metastatic breast cancer who were treated with 1 or more lines of chemotherapy, and similar magnitude of benefit was seen across all subgroups irrespective of the IHC. Destiny Breast 06 is evaluating TDXT in the broader patient population, including HER2 ultra low. And based on the Destiny Breast 04 trial, TDXT has been approved in majority of the countries. Well, approval is awaited in India, but it is recommended for HER2 low metastatic breast cancer by NCCN. It is also recommended as a second-line therapy in the metastatic breast cancer HER2 expressing tumors. Thank you.
Thanks a lot. Thank you for your talk. So moving on to the next topic, that is unraveling the path of HER2 positive breast cancer in next 2 years. For this talk, we welcome Dr. Rajiv Saini, who is a senior consultant medical oncologist at Shri Mata Vaishno Devi Narayana Super Speciality Hospital, Katra. Welcome, Dr. Rajiv.
Thank you, thank you, Chitresh, and thank you, organizer, for giving me the opportunity to share my opinion regarding this topic. Let me share my screen first. So my slides are visible?
Yes, sir, visible.
Okay. So good evening, everyone. So in this presentation, we will discuss what are the changes we are going to see in the next 2 years in Indian context. So as we know, the discovery of HER2 receptor and anti-HER2 therapy has changed the course of breast cancer disease, because earlier HER2 positive disease was considered as high risk disease, but after the discovery of HER2 therapy, the natural course of this subtype of the disease has drastically changed. So far, US FDA has approved 8 HER2 targeted agents. The first targeted agent, which we all know, is trastuzumab, which is a monoclonal antibody against domain 4 of extracellular domain 4 of HER2 receptor. So this drug was approved in 1998. And after that, multiple drugs are being approved. And there are mainly 3 classes. One is monoclonal antibody, second is oral TKIs, and third is antibody drug conjugates. In monoclonal antibody, we have 3 drugs, that is trastuzumab, pertuzumab, and margetuximab. So trastuzumab and margetuximab are monoclonal antibody against domain 4 of HER2, while pertuzumab is monoclonal antibody against domain 2 of HER2 receptor, and it prevents dimerization of HER2 with HER3. While lapatinib, neratinib, tucatinib are oral TKIs, and TDM1 and TDXD are antibody drug conjugates. But in India, majority of the Indian patients have access limited to only trastuzumab, lapatinib, and recently to TDM1 after the generic version of this drug was available in India. And as far as other drugs are considered, because of their higher financial cost, these drugs are very little affordable to the Indian general populations. Up to now, I think if we look at our clinical practice, only at the majority, 15% of patients were able to afford these drugs. But now, as we all are aware, that generic version of pertuzumab pertuzumab biosimilar is going to be available soon. So let's discuss what is the current status and how likely the change will be. Because once pertuzumab will be available, how the clinicians will going to use it, as the tentative cost of this drug will be 1/3 of what the innovator molecules have, but still the cost is a little high. And how many patients is going to afford it, and how will it change the current status in Indian context? So at present, the pertuzumab is used in neoadjuvant setting, adjuvant setting, and metastatic setting. So let's discuss one by one in next few slides. Coming to the neoadjuvant setting, as we know that dual blockade of HER2 receptor is going to increase PCR rate. If we see at the NeoSphere trial and the Definitive trial, you can clearly see in the NeoSphere trial, addition of pertuzumab to chemotherapy and trastuzumab have increased the response rate from 24 to 25% to 45%. It's almost doubling of the pathological CR rate, pathological complete response rate. While in Definitive trial, with the use of dual blockade, the response rate is as high as 80% and as low as 50% in hormone receptor positive patient, while in hormone receptor negative, it is as high as 80%. So if the patient can afford this drug, average PCR rate, which was lower, and cannot afford dual blockade, more and more patient can afford it, and and we will see the change in the prognosis of disease in Indian context also. So in NCCN guideline also, TCHP, that is docetaxel, carboplatin, trastuzumab, and pertuzumab is approved in neoadjuvant setting. So at present, adding pertuzumab in neoadjuvant is recommended mainly for tumor which are more than 2 centimeters, or if the patient is having node positive disease. So the question for the clinician and for the house is, do you consider it in all your patients, or there is any subgroup among them where you will avoid using it, or what are the various decision-making factor before using neoadjuvant pertuzumab? And with the biosimilarity availability, how will it boost the confidence and of a clinician of using pertuzumab in neoadjuvant setting? So coming to the adjuvant setting, here we have 2 scenarios. Either patient upfront get surgery, or patient received neoadjuvant chemotherapy followed by surgery. So we will discuss first if the patient received neoadjuvant therapy. So if the patient has, we have two subgroup here. One is hormone positive patient and other is hormone negative patient. So in hormone positive patients, hormone negative patient, if the patient achieve PCR after receiving neoadjuvant therapy, guidelines are to complete 1 year of HER2 targeted therapy with trastuzumab, which was category 1, but you can add pertuzumab also. But if patient has residual disease, one can go for adjuvant TDM1 for 14 cycle, or if patient discontinued it for toxicity or cannot afford for any reason, then the alternative is to complete 1 year of HER2 directed therapy with trastuzumab plus minus pertuzumab. But if in initial staging node is positive, then pertuzumab, addition of pertuzumab is category 1 recommendation. And if in case of patient, if patients are HER2 positive, again, if the patient achieve PCR with neoadjuvant therapy, then endocrine therapy plus complete 1 year of trastuzumab plus minus pertuzumab. Again, if the patient has node positive at initial staging, then dual blockade is category 1 indication. And if there has residual disease, again, the recommendation are similar to what we have with hormone negative. But in addition, we should use endocrine therapy, adjuvant endocrine therapy along with the HER2 therapy. So the question is, if patient get pathological complete response rate. So we have seen the what are the recommendations. So what are we are doing in our clinical practice? If the patient get pathological complete response, will you recommend only trastuzumab in adjuvant setting, or you will use trastuzumab or pertuzumab? Because patient has achieved PCR, should we complete 1 year of therapy, or because of the achievement of PCR, there is any recommendation for decreasing duration of therapy? And if patient did not get pertuzumab in neoadjuvant setting and did not get PCR, that is having residual invasive cancer, would you go with TDM1 in adjuvant setting, or you would think of adding pertuzumab at this point, because patient has not received pertuzumab in neoadjuvant setting? So, and if patient does not get any PATH CR, are we convinced with Catherine data of escalation to TDM1? So these are various settings where, depending upon what the patient achieve and how will we go about it. So regarding the Catherine data, in this trial, patient 1486 patient are randomized in 1:1 randomization between TDM1 and trastuzumab. In this trial, the patient received neoadjuvant therapy consisting of minimum 6 cycle of chemotherapy and minimum 9 weeks of trastuzumab. Second HER2 targeted agent is allowed. At the time of the Catherine study, pertuzumab was not approved in neoadjuvant setting. If in this study, the patient should have residual invasive tumor in breast or axillary nodes, and randomization should be done within 12 weeks of surgery. The primary endpoint of this trial is invasive disease-free survival, and secondary endpoints were DFS, overall survival, DRFI, safety, and quality of life. And patient was stratified at presentation in operable versus inoperable, hormone status, preoperative HER2 directed therapy, and pathological nodal state after preoperative therapy. So in 2019, when the TDM1 got its approval, at that time, primary analysis, which was published in 2019, has showed 11% benefit in IDFS at 3 years. And at that time, OS was immature, but it has shown trend towards survival benefit also. In 2023, the complete study was presented as SABCS, and final IDFS and updated OS analysis was presented. And in this analysis, after median follow-up of 8.4 years, updated IDFS shown 13 absolute benefit of 13.7% at 7 years, with a hazard ratio of 0.54, which was highly significant. And regarding OS, it shows absolute OS benefit of 4.7% at 7 years. And it was the first agent which has shown OS improvement in this setting. So, and if we see the forest plot of this trial, all the subset of patient has benefited with the use of TDM1 in adjuvant setting in patient who have the residual disease. Only patient where HER2 status by ISC is 1+ or 2+, they are not benefited with the or less benefited with the with adjuvant TDM1. So those patients who have undergone upfront surgery, in these patients, if the patient is node negative and tumor is more than 0.5 centimeter, in this case, adjuvant chemotherapy with trastuzumab was recommended. While those patients where nodal involvement is there, in these cases, addition of pertuzumab was category 1 and preferred over trastuzumab alone. So, what are the subgroup patients where, if they underwent surgery upfront, what were the subgroup of patient where we put trastuzumab and pertuzumab in adjuvant setting? And there was any concept of short versus standard duration in this setting. So if we see the IDFS at 8 years compared with in affinity trial with at 4 and 6 years, you can clearly see the maximum benefit which was seen is around 5% in node positive disease, while in node negative there was no benefit, and hormone positive or hormone negative disease the benefit is around 2.3 to 2.8 months percent. So the group which were benefited most with the addition of pertuzumab in adjuvant setting is those patients who have high nodal burden disease. So coming to the last part of pertuzumab indication, that is metastatic disease.
Dr. Rajiv, I would request you to please wind up in next 1 or 2 minutes.
Sure. So the pertuzumab was approved in metastatic. This drug was approved initially in the metastatic breast cancer on the basis of Cleopatra trial, and you can clearly see that this drug has shown overall response rate of 80% with median PFS benefit of around 6 months and median OS benefit of around 16 months in a metastatic setting when we added pertuzumab to existing chemotherapy plus trastuzumab. So in real world, what are the response rate and how long pertuzumab goes in first line? And we all clinicians have the experience with the use of pertuzumab in metastatic breast cancer, and I think we are using it for many of my patients has gone beyond 5 years with the use of trastuzumab plus pertuzumab combination. So if first line trastuzumab then progress, pertuzumab will, if patient has received trastuzumab and chemo in first line, and if patient progress, should we add pertuzumab or we should go to other better option? So this is all from my side, and back to organizer. Thank you.
Thank you, Dr. Rajiv, for a wonderful talk. So I found this question very interesting. If in metastatic setting a patient has received, trastuzumab plus chemo in first line, and in second line, would you go for TDM1 or would you add pertuzumab to this? So what do you do in your practice?
So ideally, if I have the option of all the anti-HER2 therapy, I think I will go with the DDXD only and HER2. But if HER2 was not available and we have not given pertuzumab in first line, I think I will go with the TDM1, because if we see the updated stratified data of the TDM1 study, those patients where pertuzumab was received initially, the TDM1 is not showing much benefit. But those patients where pertuzumab was not available or not used in first line, in those patients, the result with the TDM1 was better.
So I think that with the advent of and availability of the newer anti-HER2 agents, the best place to use pertuzumab is still the first line metastatic setting.
First line.
And on progression, there are better molecules to offer or add rather than adding pertuzumab. So thank you. I thank you very much, Dr. Rajiv, for an excellent talk and a great presentation. So thanks a lot. So moving on to the next part of the discussion. This is the panel discussion on the management of hormone receptor positive, HER2 negative metastatic breast cancer. And to moderate this session, we have Dr. Ashwin Philip, Associate Professor of Medical Oncology at Amala Institute of Medical Sciences, Thrissur. Sir was earlier with CMC Ludhiana. And I thank you, sir, for accepting the invitation. And I would also like to welcome his panelists, Dr. Kanika Sharma, who is a medical oncologist at Max Hospital, Mohali, Dr. Suresh Patel, who is a medical oncologist at Capital Hospital, Jalandhar, Dr. Neha Gupta, medical oncologist at Max Hospital, Bathinda, and Dr. Jitendra Peheljani, consultant medical oncologist at HCG Cancer Center, Jaipur. I welcome you all. I thank you for being a part of this meeting, and over to Dr. Phillips. Thank you, sir.
Yeah, thank you, Chitresh. Thank you for the organizing team. And yeah, it's been just 2 months away from Ludhiana, and are all the panelists there? Dr. Kanika, how are you, ma'am?
Good evening, I'm good, sir.
Dr. Jitendra?
Hi, sir.
Suresh, are you there? Suresh?
Dr. Suresh Patel is not there. He will join
Dr.
you.
Neha?
Yes, sir.
Dr. Kansha? Right. So all of you are medical oncologists. So I'll try to keep it as simple as possible. And if my screen is visible, just let me know. Are you able to see my screen now?
Yes, sir.
Yes, sir.
Right. So we're going looking into what we usually see on a day-to-day practice. All of us are aware about CDK4 inhibitors, and I don't think there's any doubt that we wouldn't offer it to our patients at this point of time. So we'll come to this later, but let's get to a case first of a 65-year-old lady, good performance status, presents to us with a hormone-positive metastatic breast cancer and having extensive bone mets, cervical nodes, and abdominal lymph nodes. Dr. Kanika, ma'am, de novo hormone-positive breast cancer, how would you go about this in your setting, ma'am?
So for these patients, not exactly in visceral crisis. So first I'll see whether they are symptomatic for any bone mets or there is any soft tissue component or a spinal compression or cord compression is not there. Then in the first line, I usually start with CDK4/6 inhibitor with AI.
So you would go with the CDK4/6 inhibitor with AI, and you said about looking for bone compression and pathological fractures at that point of time.
Yes.
Would you be starting them on denosumab or zoledronic acid?
Yes, sir.
So would you be using zoledronic acid a monthly regimen, or are you comfortable with the 3 monthly 12-week regimen?
For initially monthly regimen.
So you'd go for the initial monthly regimen. Dr. Neha, what about you? Is that also going to be your strategy in your setting?
Yes, sir. Same, sir. CDK4/6 inhibitor along with aromatase inhibitor along with the bone modifying agent every monthly.
Every month. Right. So Dr. Jitendra?
I usually prefer denosumab because of various reasons, like the ease of administration, no need of admission, very efficacious as per the trial data. So initially, I give 4 to 6 months of denosumab. Then, if patient wants, I shift them. And there is a good response, I shift them on zoledronate 3 monthly for at least a year.
Right. So most of you would usually give zoledronic monthly, the initial 3 to 4 months, and then maybe de-escalate later as this thing. And denosumab, yes, if they could afford and easier to give in that direction. Fine. So my questions here is, you've said, yes, performance status for you is important for all of you. Would that be the strategy, a good performance status? Or if the patient is very fit and had lesser bone mets, more of liver mets, would you still go ahead with hormonal therapy, or would you consider that this patient is fit, you would like to give chemotherapy, a weekly paclitaxel regimen? Dr. Kanika, any point of patients that you would consider for a weekly chemotherapy upfront?
So if the patient is symptomatic for bone mets, there is a liver derangement is there, or extensive liver is studded with mets, then maybe I may start with chemotherapy. But if there are even multiple, but they are small, liver function is normal, patient is asymptomatic, so maybe I'll start with hormonal in those patients.
So irrespective of the performance status, you're comfortable with the hormonal agents. Yeah, I would assume that. So you talked about visceral crisis, Dr. Neha. Suppose the patient's liver was studded, the LFT was getting deranged, and or maybe had a pleural effusion or multiple liver lung mets with SpO2 on the lower side. Are you comfortable going in with the CDK4/6 inhibitors, or would you like to give chemotherapy for like a debulking effect in these patients?
Yes, sir. If the patient is symptomatic for our mets, then I would like to go for chemotherapy first.
Dr. Jitendra, what about you?
Sir, if the disease is heading towards visceral crisis and patient had the lump for a very shorter duration of time, then probably chemotherapy will help us. Although the data suggests that response rate from CDK4 inhibitors is better, but probably none of us is more comfortable in giving in a visceral crisis of patient.
Yeah. So, I mean, there is a general consensus that if this, I mean, that's what we were always taught as oncologists, as my training was, whenever you have a doubt, chemo would not be a wrong option. But if you look at data and if you look at the Mona Lisa 7 study, they had a subset of patients who had visceral crisis who responded exceptionally well to CDK4/6 ribo and letrozole. That is, of course, after they were given ovarian suppression in whatever form it was. But if you look at the RIGHT study, which is a phase 2 study, it had around 222 patients. 50% of them had visceral crisis. And what was important in these patients is that the overall survival and the PFS was better on those patients who got ribociclib plus hormonal therapy. The only hinge in that was the time to disease control was slightly longer on the AI CDK4 arm, but that was not statistically significant. Here I tend to differ because I have not had a great experience, but in the last 8 years of my practice, I've had patients who come to me in visceral crisis, and I've used CDK4/6 inhibitors. I was biased when I first used this because I had just presented the Mona Lisa 7 study in Chandigarh, and I came back the next day. The patient came to me in visceral crisis, and I was dead scared of offering her a CDK4. I was criticized all over the place, but that patient actually did very well, and it's still alive. And she's 7.5 years. She survived 5.5 years with ribo and letrozole, and then had disease progression. So I have my biases, but I also believe the data that there is real world data showing that visceral crisis per se chemo. I mean, these hormone positive metastatic breast cancers, they work on the hormonal pathway. So I strongly believe that if you target them and have a good drug, that'll be the best way to go for. But again, it's just 3 or 4 patients that I have, and it's all my little bit of experience. Now, would this worry you, the percentage of the hormone receptor expressions? Because above 1% is what you would say HR positive. But in 2020, and right now, everything is now focusing on saying now we are not going to call everybody a hormone positive. 1 to 9% behaves more or less like a triple negative, and the outcomes are as bad as a triple negative. So if you saw this in your patient, would you still, I mean, provided this patient had only bone mets behaving like a hormone positive, would you try a hormonal therapy here, or would you say that no, I'll reserve my hormonal therapy in this patient and try chemotherapy first? Dr. Kanika, what's your take on this? 1 to 9, the low ER/PR expression.
So yes, the percentage expression did affect my decision making. But yeah, if this is the same case scenario, 65-year-old with slow progression, bone only mets, then I may start with the hormonal agent like with CDK. Based on the response, if the patient is not responding well and progressing within months, then maybe I will clinically treat it as a TNBC and then shift to chemotherapy, but not in first line actually.
Suppose this is a younger patient having liver mets, is not behaving like a typical the high HR positive breast cancer. Please pardon the kid crying in the background. We've got a 9-month-old baby at home, so yeah.
Yes, sir, that will definitely affect it. So if it's a younger patient with visceral mets and not behaving like a clinically also hormone positive, then maybe I'll go ahead with chemotherapy first, and then based on the maintenance, shift to hormonal therapy.
Dr. Neha and Dr. Jitendra, your take on the situation?
Yes, if the patient is high risk, basically younger patient with poor ER/PR positivity, I will like to go ahead with chemotherapy first based on the visceral crisis. If the patient has only only bone mets or only single mets, then I will like to go ahead with hormonal therapy. Depending on the tumor load of the patient and the age of the patient, I will like to decide upon the therapy at first line.
Yeah, the reason I brought in this is that right now we're doing a study and we're collecting data on this low 1 to 9% of patients, and technically they only come out to on 1 to 3% of your total population. And the problem is that some of those patients whom you were calling triple negative may have a low ER/PR expression. It's a bit controversial depending on the way you stain your slides, but this is an area of active interest because right now the adjuvant immuno study, which had looked at patients having 1 to 10 expression as well. So more and more you're looking at these patients and saying that they would behave like a triple negative. And if you look at the RT-PCR based, they actually behave more the triple-active subgroup. Interesting. The reason why I asked this question is because now, because of generics available, the cost has come down. But had it been more expensive, I would have been a bit more apprehensive about using a drug which was costing 50,000 rupees a month on a patient with a low ER/PR expression. So when you use these drugs, how comfortable are you all comfortable with a generic Palbo or?
Network चला गया।
Anika's connection has an issue. Dr. Neha, Dr. Anika, are you back? So generic Palbo versus innovator Abema and Ribo, are you comfortable?
So we are comfortable with generic Palbo. I've used in my 5 to 6 patients. They are behaving well with minimal side effects.
Right, Dr. Kanika?
Yes, sir. I'm also comfortable with the Palbo, but yeah, efficacy-wise, I'm more tilted towards Ribo based on the clinical experience. But otherwise, if the patient is not affordable, then I'm using the generic Palbo only.
Right. But Jitendra, you are also comfortable with generic Palbo.
So the comfortableness is depends on the patient. Patient should be able to take the treatment. So if patient can afford innovator molecule, I always prefer an innovator molecule, whether it is an CDK4 inhibitor or any chemotherapeutic agent, because the guidelines are not stringent in Indian context that much, whatever US FDA suggests. So definitely we are using comfortably, but yes, if preferred, if you can afford, you can take the innovator.
Right. So all of you are aware that if you look at all the studies, Ribo had the survival advantage in the OS. All of them had a PFS benefit. As a personal choice and my little bit of experience and the data that we collected, we are a part of a network that collects data. Our data also showed that Ribo had a much better survival advantage than Palbo, and Abema was quite similar, but the number of patients were lesser. So the real world experiences also show that Ribo probably is better. The reason I asked this will come on later because right now generic Palbo is available, but as time goes by, in a few years down, you'll have a generic Ribo available. So as a drug, like you say, Pembro has outdone everybody else and everything in the immunosection for however the drug was developed. There is a huge advantage in my mind if the patient would afford and has a reimbursement. Because my experience with Ribo has been terrific. I mean, the patient that I told you, Miss Crisis, was a young lady, 5.5 years straight away, and I've never seen somebody just walk away like that. So there are patients who do well, but again, cost is a huge factor. At what dose of Palbo do you start your patients on, Dr. Kanika?
So full dose, 125 mg only.
So are all your patients able to maintain the dose intensity at 125?
Yes, sir. With Palbo, I don't have that much issue. Maybe if the elderly patients, then because of recurrent neutropenia, maybe I shift to 100, but I usually start with the full dose of 125.
Dr. Neha, what about you? How's your experience with the Palbo 125, or do you start at 100 or something?
Yes, sir. Upfront, I start with the same dose, 125 mg. If the patient is not tolerating because of any reason, recurrent neutropenia is there or because of any liver toxicity, then I only switch to 100 mg.
So when do you decide to de-escalate, Dr. Jitendra? So from 125 to 100, how much of a time do you give this patient to recover from the neutropenia?
CDK4 inhibitor, if patient is having recurrent fatigue or patient performances is falling and we are seeing cytopenias very frequently, then probably I would like to de-escalate the dose. But usually if the patient is elder and performance is poor, like it's usually PS3-4 with diffuse bone mets who received RT, probably I will start with the intermediate dose, like 11 dose, maybe Ribo 400 and Palbo 100 if patient PS is poor.
Right.
Because they usually have difficulty in dealing with the maximum advantage what we have with CDK4 inhibitor is quality of life. If in that process you impair the quality of life, then the whole purpose get defeated.
Yeah, I totally agree with you. I mean, your aim of treatment is not just to improve the overall survival of the quality of life. So do
Sir,
you
good evening.
Yeah, Suresh, how are you, man?
I'm good, sir.
Suresh, so I'll put this to you. So Suresh, this question I asked them is, when do you de-escalate your therapy with these patients on palbociclib? I mean, suppose you give palbociclib, what I have seen is that they don't recover the counts they don't have fever. They don't recover the counts by day 28. So usually they take another 7 days or 8 days. So do you give G-CSF for these patients then, or do you wait on them?
Sir, usually in my practice, I start palbociclib at 125 mg per day. And every for the first 2 months, I keep for 2 weekly follow-up.
Yeah.
If there is fall in counts and if it is grade 3, then I go for de-escalation. Otherwise, I keep the patient on same dose.
So if you don't recover the counts by day 28, do you use GCSF or not, Dr. Kanika, or do you wait on it?
So if the patient is asymptomatic, no fever, then I wait for 1 more week. I usually don't start with filgrastim.
Okay, so you would wait a week, start with filgrastim, is still not recovering. And would you then de-escalate the dose at that point of time or wait for 1 more cycle?
Wait for 1 more cycle.
Right. Right. So this is also something that I mean, whatever I'm asking is what we are collecting right now. There's a prospective study going on real world data. And we're trying to see if, what is the nadir count that we develop, because what we've seen is the elderly patients, they somehow develop this neutropenia, which is not toxic, but it delays the subsequent cycles. So, but the data has not shown that, delaying the cycles have shown to be have a survival disadvantage as of now. But we're trying to see the outcomes in our patients as well. We already discussed this. Now we come to this premenopausal. I'll ask you a few things. This is a young lady, premenopausal, extensive disease. Here my question is, this patient has got chemotherapy in the past, has chemo-induced amenorrhea. How do you go about this? Dr. Kanika, patient has met now endocrine resistance or primary endocrine, secondary endocrine resistance. Or how do you go about this?
I did not see that, but if the patient have progressed on adjuvant hormonal therapy within the first 2 years, then maybe a primary endocrine resistance, and I would like to change the therapy. But if the patient have completed the treatment and then have started, then maybe I will see. And the other, I will see the menopausal status by doing the hormonal assays, that whether patient is actually post-menopausal now or it's just a chemo-induced amenorrhea.
So you would do the LH, FSH, estradiol levels, see if she's menopausal. My question is, would you repeat that at any point of time, or would just one value be good enough? Dr. Suresh, how would you go about this? Suresh, you're muted.
Yes, sir. In my practice, I usually repeat estradiol, LH, and FSH level on initial starting of GnRH analog, and subsequently, if required, every 3 monthly, not more frequently than that. If she's at the age of menopausal, then I will look for that.
Right. Any other takes, Dr. Neha, Dr. Jitendra, any of your takes?
Sir, usually the amenorrhea of chemotherapy returns back within 2 years. So if patient has post chemotherapy after 2 years when she is around perimenopausal age, which is somewhere written as 47 in some books, 52 in some books in India. So in that case, I will do one reading. If it is more than 2 years, then I'm more than confident to presume that she is probably postmenopausal.
So would you give them ovarian suppression if she already had chemo?
If FSH and estradiol are in, means if estradiol is less than 10, FSH is more than 40, probably I will not give.
So are you comfortable doing that, Dr. Neha? She's not there. So the reason I ask this is that when you have chemo-induced amenorrhea, your ovaries are not functioning. The SOFT and TEX trials specifically gave anti-therapy to those patients who still did not achieve amenorrhea. And then they showed that there was an advantage in the long term. But the thing is, in a metastatic setting, when you don't have such long-term benefit, or you don't have the follow-up, I'm a bit confused. If your patient already has chemo-induced amenorrhea, what's the best method? So in my practice, to be on a safer side, I do check the LH-FSH and estradiol. But there's always a fear that this thing can because it's not a permanent thing, and because it's not permanent, because to call somebody amenorrheic, you have to have those criteria, and patient is on treatment. So I tend to keep them on a 5 to 6 months checkup with the LH-FSH estradiol, because there are patients who turn out to develop cycles during this period of time in the adjuvant setting. So keeping that as a back, I continue them on some sort of a LNRH and agonist for some safety, because that is what I'm worried about, and you want to maintain that cycle. But if you were to suppress, what are you comfortable with? A surgery or medical ovarian suppression, or anybody for radical RT for the ovaries? Dr. Kanika?
So if it's a metastatic setting, then surgical or medical, both options, because she will require a long-term that. If it's a perimenopausal or we are just contemplating, then maybe for the time being, 1 year medical. But if the patient is young in their 40s, then surgical suppression. RT, I don't usually use in my.
Yeah, I got into great arguments. That's the reason I bought this here, because my RT team has come after me saying that we could do the job, and I've said no, I want a surgery, and it has ended very badly at some point of time. So I've had bad experience in this, but I strongly believe in what you said. I strongly believe the best way to go about is to do a laparoscopic oophorectomy. It's a simple procedure. One time, it gets you the headache of checking all these things on a regular basis, and it's most of the time can be done as a daycare procedure as well. So cost effective rather than, in my mind, cost effective one-time fillet. What about your take, so Suresh, Dr. Neha, Jitendra, in that order? Are you okay with doing a surgery for these patients? Because
No,
that
sir,
then
stage
comes
4
after you
surgery is
saying
the
that I
single
want a
shot
clearance and
solution.
all those things.
Oh my God. Stage 4 surgery is a single shot solution until unless patient denies for it. Otherwise, surgery is the best thing.
So I think we have a consensus that surgery would be a rational and I mean, in my mind, a cost-effective option. Right. So I think in lack of time, I'll just go towards the end and ask you a few more things, which we always discuss in all these meetings, Palbo, Ribo, and all those things we've discussed. I'm looking at the practical thing is, if you're a patient with brain mets, what would you use? Would that be a different choice in your approach? Dr. Kanika?
ABMS.
No, sir. If the patient is asymptomatic, then maybe ribociclib based, and if symptomatic, then RT followed by CDK.
Right. Suresh, Dr. Neha?
So yes, we prefer ribo in CNS meds.
Dr. Jitendra?
Sir, Abema has better efficacy
crosses
as
the
per
blood.
documentation, but Abema is a very difficult drug to give. Means if the patient PS is very good, patient is young, probably then only the diarrhea is tolerable. If some old age patient comes and QT is not a problem, then probably ribo is the way to go.
Suresh, your takes?
Sir, I agree with Dr. Jitendra that Abema is the choice, but the tolerability is very poor to abemaciclib. So, and ribo is better tolerable as compared to.
So all of you know that the preclinical data shows that Abema has probably better blood-brain penetration, but it was not proven in the studies. It is only a proof of concept that was there. Ribo also has some similar properties, again, not proven, but like you said, Abema is not a drug that I'm very comfortable with. Ribo, I've had one patient who's done reasonably well. So again, it's just one patient is not a great thing in oncology, but definitely between the three drugs, I wouldn't use Palbo because among all the three drugs, if you look at data, the Ribo and Abema had more penetration towards the CDK4 pathway and lesser to the CDK6. So they were more efficacious. That's the theory behind it. And that's what I believe, that the drugs are slightly more better than Palbo. But having said that, done, if you have resource constraints, then maybe I would give RT and then give Palbo for whatever benefit it's going to give. But otherwise, yes, like all of you said, I would consider Ribo because Abema diarrhea can be a big issue and then the quality of life and all comes down.
So last 2 minutes, please.
Yep. So I'm just winding up. This is the data that I told you, the real world data that is there showing you that vessel crisis, you could use CDK4/6 inhibitors. And any of you would use CDK4/6 inhibitors in the second line on disease progression? A last round quick. Dr. Suresh? Dr. Neha, while he switches on his mobile. So, Dr. Neha?
Yes, sir. I would like to go for the CDK4/6 inhibitor, but I will change my endocrine therapy. I would like to go for fulvestrant.
You would change the hormonal therapy backbone and continue CDK4/6. Jitendra and Dr. Kanika?
Sir, if NGS is negative, response is good. Response is good means at least more than 1 year of PFS, then probably I will go ahead with. If any other thing is given prior, probably I will switch to Ribo.
Okay. Dr. Kanika, any other thoughts?
So same, if there is a differential response and there is not a frank progression, then maybe just changing a one endocrine therapy back, and I'll continue with that.
So I had just seen this data. I have to read that study in detail, but yeah, this is a reasonable option, but in my little picture, it's not really worked too much. Just one final take. Question is, the Sonia study, if you're aware, was a Dutch study. It's a government-sponsored study to look at the cost effectiveness of giving a CDK4/6 inhibitor upfront or in the second line setting. Now, considering the fact that India, you have generics, would you at any point of time considering keeping your CDK4/6 inhibitors as a reserve? And my only thing is that, like I at the beginning of talk said, that considering the generic ribo may come in the next 1 or 2 years, would you consider reserving your CDK4/6 inhibitors and using fulvestrant upfront and then using your second line CDK4/6 in an Indian setting?
So if cost is too much of a constraint, then maybe, but otherwise, just reserving some good therapy for the second line, I don't think it makes a sense, because patient who has started upfront on CDK4, they have a longer disease-free survival. So I
Right.
would not
So the
reserve.
Dutch study showed that those patients who were studied upfront did slightly more better than the patients on the second line. But if you look at the cost effectiveness, it didn't make sense, because the cost effectiveness, because again, they are only using innovators, they are not using generics. So that's the reason the study was done in the first place. So, I mean, I don't think this is applicable to India as of now, because we do have access to it. And I always believe that you could use your best therapy upfront to get the best results upfront. Yeah, so anybody would be in this era of CDK4/6, have we completely left out the Bolero 2 in the second line, exemestane plus everolimus? Is it a completely off the hook option, or are we looking at greater agents that are coming in now, which are again very expensive, and I can't even think of using it in my patients? But any of you would ever think of the small option that was there when I was a PG student?
That I don't think it's a small option, and I am routinely using it, because after CDK4 and AI, there is not much option. And some patients who are resistant and they just progress after 1.5 years, there is very less option with hormonal therapy also. So yeah, I am using this combination actually.
Yeah, so I don't think it's a bad option. It has a bit of toxicities with everolimus, but in the circumstance that we have, it's a reasonably good option before you put the patient on chemotherapy. Yeah, so I'll wind up for the lack of time, and I want to thank all of you for spending some time. And it's good to catch up with everybody from the north for 3 months. Thank you so much.
Thank you, sir. Just one question from my side to you and the panelists. Instead of considering Bolero 2, what are your thoughts or opinion on changing the CDK4/6? Anybody progressing on ribociclib plus AI? What about offering abemaciclib?
Yeah, see, the thing is, Chitresh, there's no data for that. They've tried some of these things in some studies. But the fundamental thing is that if you ask me, if you have progressed on paclitaxel, if switching immediately to docetaxel, would it make a great difference? Not really. So and when you have other options, I think you should switch to other options. And maybe down the line, if you have no other options, the patient doesn't want chemotherapy, you could bring it back and see if it works, but not immediately after there's a disease progression, because principally the difference is that you could probably say that CDK4 activity was higher in ribo and abemaciclib, but there isn't enough data, and I wouldn't, and it's costly. So to use that thing in the second line without evidence would be tricky. So that's my take.
Correct. Thank you, sir. And I thank you and all the panelists for taking out time and having a healthy discussion. Thank you.
Thank you.
Thank you, sir. Thank you, sir.
So moving on to the next session. The next session is again a panel discussion on the management of HER2-positive metastatic breast cancer. And to moderate this session, we have a dear friend, Dr. Ravi Jaiswal, who is a consultant medical oncologist at Ramakrishna Care Hospital, Raipur. And the panelists would be Dr. Mukesh Bansal. He is a consultant medical oncologist and head of Alchemist Hospital, Panchkula. Dr. Deepak Singla, he is a consultant medical oncologist and head at Indus Hospital at Deravasi, Mohali, and Ambala. And Dr. Yoganshu Gupta, he is a consultant medical oncologist at MMU Medical College and Hospital, Ambala. So over to you, Dr. Ravi.
Thank you, Dr. Chitresh Agrawal, sir, for the kind introduction. And first of all, I would like to congratulate you and your team for organizing a good academic virtual event. And at this outset, may I invite all my panelists to please put on their cameras and their voice so that I can actually see you, so it becomes easy to have this panel discussion. Dr. Mukesh Bansal, sir, yes, I remember meeting you.
Hello, sir. How are
in
you?
Kashmir.
Yeah,
Dr. Yoganshu, sir, hello, sir.
Hello, good morning, sir. Good evening, sir. Sorry.
And Dr. Deepak, sir. Dr. Deepak, sir, is with us.
Yes. Good evening.
Hello, good evening, Dr. Deepak, sir. So, in this panel discussion, because Dr. Chitresh Agrawal has given me this panel discussion as a last minute replacement for somebody, so I couldn't really work hard on my slides. But what I would do is, I would like to discuss more practical aspects as to what we actually do, because we don't have that access to, let's say, tucatinib, neratinib, deruxtecan, and so on and so forth in day-to-day practice. But then when we get such patients of metastatic breast cancer and who express HER2, how should we approach this patient? So how is it visible to all of you?
नहीं जाएंगे
My slides are visible?
सर
Yes, sir, visible.
Thank you. Thank you. So we all know that HER2 positive breast cancer today has become a chronic disease. And earlier it used to be a dreaded poor prognostic disease. But now we sometimes feel happy when we get a report and the patient has HER2 3+ positive, because we know that now for our treatment armamentarium, we have a lot of treatment options for these patients. So majority of these patients would be getting chemotherapy with a single anti-HER2 or a double anti-HER2, and even they progress, we have options to treat these patients. So these patients are going to survive for years now. So it's not survival for months. We are talking about years in terms of overall survival. And if we see what all agents that have in our armamentarium, so we earlier had only trastuzumab, which used to bind on domain 4 of HER2, and then came another anti-HER2 drug, which is pertuzumab, which binds on domain 2, and it prevents the dimerization and subsequent down signaling pathway, which is the PI3K, AKT, mTOR from getting activated. Moving from our monoclonal antibodies, we now also have antibody drug conjugates. So we have TDM1 and TDXD, which have entirely changed the treatment landscape of these diseases. But how these drugs should we utilize in our practice? That is what is the purpose of today's panel discussion. So, right. So these are various trials for HER2 positive breast cancer, which our earlier speakers have very nicely demonstrated, right from Cleopatra to Emilia, HER2 Climb, and the recent trastuzumab deruxtecan Destiny study. So how should we apply this knowledge in our practice? So let us go to our first case, and I will begin with Dr. Mukesh Bansal. So Dr. Mukesh, we have this young lady who is 40-year-old and who has a 4.4 centimeter lump in her breast, and there are 3 palpable axillary nodes. So over to you. So how are you going to work up this lady?
Sir, I will do a core biopsy and send ISC for ER/PR, HER2 and Ki-67, and I will do a PET CT scan of the whole body, and then according to the staging and the marker status, we will proceed.
So you asked for it, and these are the investigations we have for you. So what are you going to do now?
So it's a HER2 positive, HER2 positive, node positive disease. So I will prefer neoadjuvant therapy, and I will like to start with TCHP if the patient is affordable, or TCH.
So we are dealing with a metastatic case because there are 3 liver lesions.
Okay, sorry, I missed that on the CT.
So you missed that.
So
we have 3 liver lesions. The largest is 3.1 centimeter in the liver.
Okay, so we can.
Case or this is a palliative case? What is your thought right now? You have a young lady, only 40-year-old.
It's a palliative case. I think 3 liver lesions with largest 3.1 centimeter, and I will approach with the taxane plus dual anti-HER2 if affordable.
Okay, so now everybody agrees, Dr. Deepak sir, Dr. Yuganshu, that Cleopatra is the way to go, or there is any debate?
No, sir, no debate. I will go ahead with same. Taxane plus dual anti-HER2.
Yes. Go ahead, Yuganshu. Yuganshu, go ahead.
Sorry, sir. Pardon, sir. Kindly.
Yeah, it's okay. I mean, triplet is the way. I mean, because this lady is ER/PR negative. If she would
Yeah.
have been, ER/PR positive, then we could have thought of, because of low burden of the disease, we could have thought of giving some hormonal treatment plus dual anti-HER2. But right now, THP is is my stand. I mean, this will be my choice.
Okay, so like everybody agrees that we want to use our best drugs upfront. And that is the reason why Cleopatra has shown us that there's 16 months of overall survival benefit from 40 months to 56 months. So usually we don't see this in stage 4 metastatic diseases. But 16 months of overall survival, undoubtedly, THP today has become a standard of care for most of our patients. Now, let us think this scenario in another way. So let me go to Dr. Yuganshu. So Dr. Yuganshu, this case was an ideal scenario for you. But let us say most of the patients that we see in our practice, they are performance status 2, performance status even 3, multiple liver lesions, multiple lung lesions. So for these patients also, you'd be considering THP regimen, or you have certain another options for these patients?
So usually I start these patients with single HER2 plus taxane, and in the second or third cycle I add pertuzumab to these patients.
Okay, and you will use docetaxel, or you can even give paclitaxel for these patients, weekly
Sir,
paclitaxel.
weekly paclitaxel I've added to a few patients, and they do very well with trastuzumab, weekly trastuzumab.
So Dr. Deepak Singla, sir, is there any place for not giving chemotherapy and only giving dual anti-HER2 therapy? Is there any place in your practice?
Yes. I mean, yes. If the low burden of the disease is there, then I may avoid taxanes, or I may avoid chemotherapy. But provided, as you have given the scenario right now, I mean, the patient is having multiple lung mets and multiple liver metastases, and here is use of cytotoxic chemotherapy is warranted. And secondly, not necessarily with the docetaxel, I may go ahead with the weekly paclitaxel also. I mean, I can substitute this taxane.
So, Dr. Mukesh, now that we are so fond of using Phesgo, that is the subcutaneous form. So, in your practice also, do you use upfront Phesgo with docetaxel, or you stick to standard protocol of IV trastuzumab, pertuzumab, same loading dose, same combination?
No, sir. In most of my patients, I have replaced IV with subcutaneous. I think it's easy to administer, and I have not gotten any significant side effects which were not there with the IV form. So I'm comfortable with Phesgo.
Okay. So let's say you start somebody on Phesgo, and then you're not sure which drug is leading to side effect. And then how do you tailor?
I think the most common
Let's say
side
you want
effect
to,
which
let's say
yeah.
your patient is getting more diarrhea, getting PR bleed, and you somehow want to attribute those side effects to pertuzumab, and the company is saying that we won't give you trastuzumab, you have to stop Phesgo. Then doesn't this become a problem?
I think the most common side effect I have gotten is diarrhea, and obviously, I think the diarrhea is mostly due to pertuzumab component only. If the diarrhea is so significant that we have to stop the pertu, then obviously we have to shift to the IV. I think even if the IV combination is going, we cannot attribute which side effect is due to which drug, because both of the drugs, all the drugs are given in the same day or in the same cycle. So I don't see it as a practical problem.
Okay, agree with you. So, Dr. Deepak sir, I come back to you again, and let us say that this lady had multiple brain metastases. So more than 5 brain lesions in different lobes. So how would have you approached this patient?
Yes, I mean, if de novo brain mets are there, so I would like, sorry?
De novo, yes.
Yes. So I would like to use TKI plus, plus oral form of chemotherapy.
So you want to say that first you will radiate the brain and then you will
No. I'm not saying that.
Okay.
I'm not. if the patient is asymptomatic, I will go for a lapatinib plus capecitabine regimen.
So you are saying that if the patient has brain metastasis, you don't want to use THP regimen, you want to use upfront lap cap. Is that correct?
Yes.
Dr. Yuganshu, you also want to say the same, or you have a difference of opinion?
I would preferably treat with WBRT followed by HER2 agents with taxane.
No, so you want to do radiation for those 5 lesions.
Yes, sir. WBRT. Yes, sir.
And then you
Hippocampal
want
sparing WBRT.
Yeah. And then after your your whole brain radiation, what do you want to do?
So dual anti-HER2 agents with taxane only.
Dual anti-HER2 agents. Which dual anti-HER2? You want to give the THP to the lady, or you want to give trastuzumab lap cap to the lady?
Sir, THP to the lady.
Yes?
Sir, THP.
THP. Okay. And Dr. Mukesh, what is your opinion? What do you want?
So if the patient is symptomatic, then obviously first whole brain RT and then followed by THP. If the PS performance status is good enough for the taxanes, or otherwise, then we can consider lap cap also. If financial issues for HER2 are there, or
I am interested only in first line, Dr. Mukesh. So what is your first line? Because your first line is going to give maximum survival for this patient.
THP, sir. Whole brain RT followed by THP.
THP. So Dr. Deepak, sir, let me come back to you again. So do you still want to give upfront lap cap, or you think the strategy to radiate these patients and put them on THP is better? What is your thought?
No. I mean, if the patient is asymptomatic, I was talking about if the patient is asymptomatic.
Okay, she has 5 multiple brain lesions. Let's say she is symptomatic. Okay. Let's say she's symptomatic. Okay.
I mean, then my strategy will be, I mean, I will go ahead with the first radiation first.
And then after radiation?
I mean, I will go for the taxane plus dual and anti-HER2.
So, what is the blood-brain barrier penetration for trastuzumab and pertuzumab? Any guess, any number?
I mean, penetration is very poor there.
It is around 10%.
Yes, only 10, maybe less than that.
Yeah. So, but even if you see the Cleopatra study, they had patients who had brain metastasis and saw patients who had more than 3 brain lesions. Even though the patients were not symptomatic, they had radiated these patients because for them, more than 3 lesions is a high risk of CNS progression for these patients, and you cannot put them on wait and watch approach. So their approach was to radiate these patients, and they all had advocated to continue THP rather than your TKI as a first line regimen. That is the reason why I put this question to all of you. So let us go ahead, and our patient, like you all suggested, that we should do THP for these patients because your Cleopatra is giving you 16 months of survival benefit.
Ravi, last 3 minutes, please.
Okay. We'll cover up. Right. So now let us talk about some second line options for our patients. So Dr. Yuganshu, let me come to you and let me discuss with you that once these patients progress on THP regimen, so what treatment options do you have and how do you sequence your subsequent treatment regimens?
Sir, I don't have any experience with TDX, though if available, I will prefer that. Otherwise, I'm using TDM for now on first line progression.
Okay. So is there any set of patients who would benefit more from TDXD than TDM1?
Especially with brain mets patients. The brain penetration of tucatinib and TDX is more than TDM1. So I will prefer in brain mets patient TDX or tucatinib based regimen.
So Dr. Deepak sir, let's say if the patient has prior pertuzumab usage, does that also help you in deciding your second line treatment option for the patients?
If the patient already had used pertuzumab.
Yeah, because there are certain studies to suggest that if your patient has already been exposed to pertuzumab, trastuzumab combination regimen, they have lesser HER2 expression, and there your TDM1 becomes less effective, and trastuzumab deruxtecan is more beneficial. That is why I was asking you this question.
No, I mean,
Dr. Mukesh, let me come. So, Dr. Mukesh, let's say that you've started the patient on TDXT in the second line, and or TDM1 in the second line, and then after 6 months or 7 months, your patient has started to progress. So, in how many percentage of your patients with HER2 positive metastatic breast cancer do you actually rebiopsy them, look for HER2 status, look for NGS? How is your practice in more than second line and third line and beyond?
Sir, I like if the patient has progressed in 6 to 7 months only, I will like to rebiopsy the patient. But practically, I think in 50 to 60% or 70%, you can say I am able to rebiopsy the patient due to technical issue, financial issue, or refusal of the patient. And I think sometimes we do get that the HER2 has become negative. The patient has got converted into triple negative also. And about the second and third line therapies, I have no practical experience of TDXD. So I'm relying on TDM1 only. And the other option is LabCap regime. I think it's a very good regime, especially giving the option of oral therapy to the patient. And that's it.
So what is your experience with LabCap, Dr. Deepak Singla, sir, in your practice in the third line? How many patients are able to tolerate your 1000 milligram of lapatinib, or you have to cut down the dose because of diarrhea?
I mean, currently I'm having two patients. I mean, they are young patients, and fortunately, they are tolerating it well. I mean, I don't have to cut down the dose. I'm managing the diarrhea with anti-motility drugs. So I mean, they eventually settle down. Majority of time, they eventually.
So that's not a major concern to you.
Not right now. I mean, not right now.
Okay. So now I am quickly going to summarize, and I have just two questions before I summarize. The first question I would go with Dr. Yuganshu. So Dr. Yuganshu, for young patients with oligometastatic HER2 positive breast cancer, let's say if you have the similar lady with a single liver lesion or a single lung lesion, do you ever think of doing a curative option for this patient? Like if the patient has a very good response, will you ever consider for SRS or a surgery for the oligometastatic disease? Or that is out in your practice?
So though the data is available only for ER/PR positive patients, that too only with brain mets. Only one trial was positive, that was a Turkish trial. But in my practice, we have treated some TNBCs also and HER2 positive also with curative intent, and the results have been very, very good.
So Dr. Mukesh, what is your experience about oligometastatic HER2 positive breast cancer? Oligometastatic means not 5 or 7, let's say 1 or 2. Will you think about treating them with a curative intent? Dr. Mukesh or Dr. Deepak, anyone can take.
Sir, if the patient is young and fit, I will definitely go with the curative intent.
Okay, so I think we all are started to agree now that HER2 positive metastatic breast cancer is no longer such a deadly disease, and there are certain amount of patients with availability of fantastic new drugs that it has become a chronic disease, and we may even think about treating these patients with a curative intent. And we all have patients who are on Phesgo for 50 cycles and 60 cycles, and with trastuzumab deruxtecan coming in, even in second line settings, it has totally replaced TDM1 in the practice with a PFS of 0.28 hazard. Where do we see this in our practice? So I think very slowly these drugs will come into first line, and we would be able to even cure many patients with metastatic HER2 positive breast cancer. In the interest of time, we will skip other discussions on HER2 low breast cancer, and I would go with my summary slide. And my summary slide is this, that between first line option, we don't have a debate. We all will be using trastuzumab, pertuzumab, and docetaxel based on the Cleopatra regimen. For our second line option, we prefer trastuzumab deruxtecan over TDM1. And for the third line, we have options like lapatinib, capecitabine, or tucatinib, trastuzumab, capecitabine for most of our patients. So thank you so much, all my panelists and Dr. Chitresh Agrawal sir, for having us. If there are any questions or any discussions my panelists want to bring into, please go ahead.
Thank you, Dr. Ravi, and all the panelists. Just one point I would like to make is that that though T-DXd is a very, very effective drug, but I would like to mention that it is a very, very difficult drug to give also, because we have 2 patients presently running on T-DXd, not in the first and second line, but patients have progressed multiple times on trastuzumab, chemo, TDM1. And such group of patients, they have had a marvelous response on the PET scan. So there is one patient who has, literally got a clearance of PET scan disease-wise, but the tolerability is very poor. In the context of fatigue, in the context of abdominal discomfort, we only talk of, ILD and related symptoms. But I feel that the fatigue and the abdominal discomfort for both of my patients has been a struggle, to this level that despite being a very, very good response on the scans, they are not very convinced to continue T-DXd. Now, it is a talk of only 2 patients, so it is not such a big number to, derive significant conclusions. But most of the patients, they have this, at least in my practice, I have seen this. I would like to, ask your experiences regarding this.
So, sir, I have 3 patients on T-DXd. One is gastric cancer, where the dose is a little higher than the breast cancer. And that lady in the second line is able to tolerate with little bit of fatigue and, like you said, abdominal discomfort, but it does not lead to any treatment interruption or dose reduction. The other 2 patients are breast cancer, and they are also doing relatively well. So I think we are not able to see that in the practice. And if you look at the trial data also, the discontinuation rate is less than 10%. So
that is good. So discontinuation rate in a side effect profile is rather encouraging, but still it is, I think, difficult to do rather than TDM1. TDM1 is a relatively more simpler drug to do. Chalo, thank you all. Thanks, Dr. Yoganshu, Dr. Deepak, Dr. Mukesh, and Dr. Ravi. I thank you all for, having such a healthy discussion. So moving on to the next topic, that is IO in TNBC, and I would request Dr. Jitendra Arora from Patel Hospital, Jalandhar, to please give his talk on this topic. I welcome Dr. Jitendra, and I thank you for his participation.
Thank you, Dr. Chitresh. Can you please share my slide?
Yes, sir, sure.
Nishant, please share Dr. Jitendra's slide.
Yes, sir, yes, sir.
So Dr. Chitresh has given this topic 2-3 days back to me. So I start with this. So what is the role of immunotherapy in breast cancer? Please, second slide. So what is the rationale of combining the immunocheck inhibitor? Previously, they said that there is no usefulness of the immunotherapy in the breast cancer, but after that they see that there is a infiltration of tumor infiltrating lymphocyte, then previous studies suggest that there is some response with the immunotherapy. So the rationale for combining the immunocheckpoint, rationale of using the ICI in the DNBS is tumor-infiltrating lymphocyte, PD-L1 expression, and some non-seminous mutations like neoantigens which are formed by this. Third slide. So in the previous study, they have seen the single response of monotherapy of the atezolizumab and pembrolizumab agent in the triple negative breast cancer. The studies of KN012, KN086A, and KN086B that include the pembrolizumab, and the overall response of the monotherapy was 18.5% in the KN012, whereas in KN086 and B it was 5.3 and 21.4%. And the atezolizumab single agent, there was 10% of overall response rate, and avelumab single agent was there is 5.2%. Next slide. So in the neoadjuvant setting, there are the phase 2 randomized phase trial I-SPY 2. There are 3 arms with paclitaxel combination with the pembrolizumab, and the other were the HER2 arms. They include 4 cycles of paclitaxel with pembrolizumab, and then followed by the doxorubicin with cyclophosphamide in the 4th cycle, followed by surgery. And the control arm include the paclitaxel 80 milligram every week for 12 cycle, and the experimental was paclitaxel with pembrolizumab 3 weekly. Next slide. So the estimated pathology complete response rate and EFS was PCR in TNBC was there was more than 99% success rate in the phase 3. As you can see, the EFS by PSR, the combination of the pembrolizumab, there was 0.8% event-free survival at the 3.5-year median year survival, and in the single non-combining pembrolizumab, it is around 3 years. Next slide. What were the adverse effect noted in that? The adrenal sufficiency was previously seen, but they have seen that the grade was not that much after post hoc analysis, but hypothyroidism, hyperthyroidism, and adrenal efficiency was the prominent adverse effect in this trial. Next was the neoadjuvant Keynote 522 study. It was included the T1C, N12, T24, N0, and TNBC breast cancer disease, and the primary endpoint was the pathological complete response and EFS by local view, and the secondary endpoint was pathological complete response, overall survival, EFS, and adverse effect. So the neoadjuvant phase include the carboplatin plus paclitaxel 4 cycle, followed by the doxorubicin or ipurubicin plus cyclophosphamide plus pembrolizumab, and another one the same regimen plus placebo, then followed by surgery, and then followed by the maintenance of pembrolizumab 27 weeks. Next slide. So the primary endpoint, there was a combination, as you can see, pembro plus chemo 64.8% versus 51.2%, and by PD-L1 status of the tumor, the response is 4% more than the irrespective of the PD-L1 status, 68.9 versus 64.8%. Next. So EFS include 84.5% in the combination of pembrolizumab with plus chemotherapy, whereas 76.8% was there in placebo plus chemo with hazard ratio of 95%, including 0.63%. Next. And the EFS was 94.4% in the combination arm, whereas 67.4% without the combination of pembrolizumab. Next slide. And the adverse effect was there. As you can see there, any grade was 43.6% the combination arm, grade to 3 to 5 was 14.9, and lead to that was only 0.3, whereas in the placebo it is 0, and discontinue was 10.9 due to adverse effect in the combination, whereas it is in placebo it was 2.6. Next slide. Third, there was IM patient 031, there is an addition of atezolizumab in neoadjuvant setting in stage 2 3 TNBC. It was included the PDL status more than 1%, less than 1%, and the combination was atezo plus nab-paclitaxel, atezo plus doxorubicin, cyclophosphamide 8 week, followed by surgery, then the 8 doses of adjuvant after the surgery. And the second involved the placebo plus nab-paclitaxel, same regimen, and then the observation after the surgery. So primary endpoint was the intention to treat population and PDL subpopulation, and the secondary endpoint EFS, DFS, and overall survival in the patient with PDL1 subpopulation. Next slide. So the result was there is a pathological complete response in ITT population. 58% was there in the combination of, whereas is the 41% without the combination of atezolizumab. Next slide. By PDL1 status, they have seen that there was a 69% of the PCR versus placebo plus CT, and PDL negative arm includes 48% versus 34%. Next slide. Another trial was there is a Gapra neoadjuvant durvalumab in TNBC, and they have included TIL rather than the PDL status, and the tumor size included more than 2 centimeter, and they combined that they have completely used the durvalumab in the neoadjuvant. They have not given the maintenance phase. So the dose was 0.7 gram IV. That is called the window that has been included in the pre-trial. Then they have included the 12 week of including the durvalumab plus nab-paclitaxel for 12 weeks, followed by the 8 weeks of the EC and then surgery. And there was no adjuvant durvalumab. Next slide. So the pathological complete response was 53.4% versus placebo, and the overall response at 1.45, and the 3-year overall survival was 95.2% versus placebo 83.5%. Next slide. So these are the trials. The previous slide trials was included in the newer setting. What was the role of immunotherapy in metastatic setting? Please show the next slide. So the main prominent trials were the IM patient 130, IM patient 131, and Keynote 355. So the IM patient 130 and 131 include the atezolizumab in both the trials, whereas Keynote include the pembrolizumab, and the percentage of prior taxane therapy was 51 to 53, and 45%. The chemotherapy include was nab-paclitaxel, paclitaxel or nab-paclitaxel or gemcitabine and carboplatin. And the progression-free survival was 55 versus 7.2 in the IM patient, whereas in 31 IM patient was 131, 5.7% was 5.6 months with hazard ratio 0.86, and in pembrolizumab arm it was 7.5 versus 5.6. And the when PFS was analysis with PDL1 status, in atezolizumab arm it was 7.5 months versus 5.3. In 131 it includes 6 months versus 5.7, and in pembrolizumab arm it is on 9.7 versus 5.6. Overall survival rate with the PDL status, there was 23 months of the overall survival in pembrolizumab plus chemotherapy arm, whereas in atezo arm it is almost 25.4 to 22.1 in including both 130 and 131. The adverse effect was around 57.3 and 62% in the IM patient 130 and 131, whereas Keynote 335, 355 it is to 26.5. So these were the main clinical trial which has been performed in the metastatic TNBC, which included the PDL1 status as well as the without PDL1 status. Next slide. So what is the novel strategies including the new trials which are coming? There is a combination of the PARP inhibitor with the immunotherapy. What is the rationale of combining the PARP inhibitor with the immunotherapy? It upregulates the host anti-tumor response, and they form the new antigen which help the immunotherapy to regulate the tumor's response. And in medulla, there is a combination of olaparib with durvalumab. These are the trial where germline BRCA mutated metastatic breast cancer was included, and the overall response rate was 58.5% in medulla trial. And the third one is the Topicio. There is a combination of pembrolizumab with niraparib with overall response rate 21%. So in future, maybe we are going to combine the immunotherapy with PARP inhibitor. Next slide. Another phase 2.
Dr. Jitendra, I would request you to please wind up in next 1 minute.
Yes. I-SPY 2 neoadjuvant durvalumab. There is a combination of durvalumab plus olaparib and combining with taxane with doxorubicin and cyclophosphamide. So the second rationale of combination with ADC with plus ACI. So why there is a combination of ADC? Because ADC activate dendritic cell which increase the expression of PDL1. So maybe in the future, maybe we are going to combine the sacituzumab with the pembrolizumab or durvalumab. Next slide. So these are the some trials which are going on where they have done the combination of the with chemotherapy and the newer things with like BRCA inhibitors and the ADC. Next slides. So what are the biomarkers which are going to be selected for the ICI therapy? Immunochank expression that can include the Ventana and SP142, 22C3, DACO and Ventana. Another is a tumor mutation burden, TMB, and the TIL score. These are the biomarkers which can be used for the selection of the immunotherapy in triple negative breast cancer. Next. So what is the future direction? There is a upcoming novel immunotherapies like lymphoactivation gene 3, cancer vaccine PVX410, immunotherapy combined with the HER2 breast cancer agent, and the immunotherapy in the hormone receptor positives. Next slide. Thank you very much, Dr. Chitresh. I have rounded up.
Thank you, Dr. Jitendra. I am sorry that I gave you this responsibility at the last moment, but still it was an excellent presentation. And I thank you. Thanks a lot for accommodating our request. Moving on to the next session. Now from breast cancer, we would be moving to lung cancer. And I would request Dr. Pravesh Dhiman to give a talk on redefining the management of non-small cell lung cancer with atezolizumab. It is a session which is sponsored by Roche. Dr. Pravesh Dhiman is a senior consultant and he works presently at All India Institute of Medical Sciences, Bilaspur. Welcome, Dr. Dhiman, and I request you to please give your talk.
Thank you, sir. I would like to start getting my slides first. Or the organizers can share my slides, please.
Yes, sir. Yes, sir.
Okay. Okay. First of all, I will thank Dr. Chitresh for giving me the opportunity to speak on this platform. So, as we all know that lung cancer is a heterogeneous disease, and nowadays in last decade we have seen the marked improvement in the management of lung cancer. So now the treatment of lung cancer is biomarker based. So the biomarkers, all we know that either these are PDL1 status or the other biomarker, this molecular markers like EGFR, L-cross and other markers. So this treatment has become individualized. I will be speaking mainly of the role of atezolizumab in lung cancer. So next slide, please. So I will be mainly discussing the 3 trials IMpower 110, which looked at the is atezolizumab monotherapy is better agent than chemotherapy in PDL1 selected chemotherapy in naive patients. Second will be other will be IMpower 130, that steroid sparing chemotherapy regime is better combination partner for atezolizumab, and IMpower 150 does addition of atezolizumab to the combination of bevacizumab plus chemotherapy will add to the clinical benefit. So next slide, please. So in IMpower 110, the inclusion criteria was stage 4 non-squamous or squamous non-small cell lung cancer. These patients were PDL1 selected and EGFR negative. And these patients were randomized into atezolizumab monotherapy followed by atezolizumab maintenance therapy. In the non-squamous histology, the randomization was with carboplatin or cisplatin plus pemetrexed, and squamous histology received carboplatin or cisplatin plus gemcitabine. And they went on to receive the maintenance in non-squamous pemetrexed, in squamous best supportive care. So primary endpoint was overall survival, PFS, overall response rate, and the duration of response. Next slide, please. So in this, we can see that there was a marked OS survival benefit of 7.5 months in patient treated with atezolizumab over chemotherapy. So this was highest in the patient who had high PD-L1 expression, that is more than 50%. Next slide, please. So you can see, we can see there that there is PFS benefit of 60.3 months. 6 months PFS was 60.3% and 38.3% in chemo arm, thereby indicating that if PD-L1 selected patient, those who have more than 50% expression, monotherapy was a very good option. Next slide, please. So in this patient, the response rate were also higher. Patient having PD-L1 more than 50%, 40.2% versus 28.6%. Next slide, please. The OS benefit in PD-L1 high subgroup, if we select the any assay with different assay, the survival was similar. Even with the SP142 or DECO or SP263, the overall response rate, this overall survival was similar in all these groups, and these showed the that benefit of atezolizumab monotherapy in TPS more than 50%. Next slide, please. So the safety analysis were similar to the presented at earlier analysis. Next slide, please. And all causes of adverse effect, we can see that with chemotherapy, the myelosuppression related side effects were higher, and with the atezolizumab therapy, these were immune related. Next slide, please. So, in summary, this study was a positive study showing that benefit of overall survival in PD-L1 selected population, and safety profile of atezolizumab consistent with previous observations. Thank you. Next slide, please. So IM Power 130, it was a phase 3 study of carboplatin and nab-paclitaxel with or without atezolizumab in first line advanced non-squamous non-small cell lung cancer. Next slide, please. So randomization was 2:1. Arm A received atezolizumab plus chemotherapy, that was nab-paclitaxel for 4 to 6 cycles, followed by maintenance of atezolizumab therapy, and the other arm was a carboplatin plus nab-paclitaxel followed by pemetrexed maintenance. Next slide, please. So next slide, please. Next, this I think all of us know the mechanism. Next slide, please. Next slide. So basically, the rationale, this primary aim of this therapy was the steroid sparing effect, the combination of nab-paclitaxel. Next slide, please. Next slide, please. So in this, we can see that atezolizumab for chemotherapy at 6 months, the PFS was 56.1%, and in chemotherapy arm, it was 42.5%. The hazard ratio of 0.64, clearly indicating the benefit of combining atezolizumab with chemotherapy. Next slide, please. So the PFS benefit was observed across all the relevant subgroups, be it by sex, by gender, or age, or ECOG performance status, liver mets, or PD-L1, all this across the all subjects like PD-L1 negative, low, or high. Next slide, please. So overall survival benefit was also higher in patients receiving atezolizumab with hazard ratio of 0.79, and the benefit of overall survival was around 6 months. Next slide, please. So, and this overall survival benefit persisted throughout the groups. Next slide, please. And addition of atezolizumab to chemotherapy with the intention to treat the overall response rate, partial response were higher in atezolizumab combination group and compared to the chemotherapy alone this group, and it was highly significant. Next slide, please. So IM power 130 showed us that this addition of atezolizumab to chemotherapy improves both OS and PFS, and it has a good safety profile. So next slide, please. The next, the last trial which we'll be discussing, IM power 150. It was a study of atezolizumab plus chemotherapy and bevacizumab in first line metastatic non-small cell lung cancer. The next slide, please. The inclusion criteria was stage 4 recurrent or metastatic non-squamous non-small cell lung cancer, chemotherapy naive, and these were stratification factors were gender, PD-L1 IHC expression, and liver metastasis. So it had 3 arms with 1:1:1 randomization. Arm A was atezolizumab plus chemotherapy combination. B was atezolizumab plus chemotherapy plus bevacizumab, and arm C was bevacizumab plus chemotherapy. So maintenance is as shown in the arm. One was the atezolizumab maintenance, second was atezolizumab plus bevacizumab maintenance, and last was this bevacizumab maintenance. Next slide, please. So in this we can see that these patients, there was well balanced patient subsets. So in this patient, in this study, 14% of patients had liver metastasis at baseline, and 10% of patients had EGFR mutations, and these patients were balanced across the 3 arms. Next slide, please. Next slide, please. So there was significant overall survival benefit with the addition of atezolizumab to this chemotherapy and VEGF inhibitor therapy, and we can see that the median PFS, median survival overall survival was 19.5 months in the atezolizumab combination group with the VEGF inhibitor and chemotherapy, as compared to 14.7 months in the arm C. So there was OS difference persisted up to 24 months. So next slide, please. So overall response rate and duration of response were also improved in the intention to treat population, and we can see the higher response rates were with the arm B as compared to arm C and arm A, and it persisted across the subgroups like PD-L1 high, low, or PD-L1 negative. Next slide, please. Next slide, please. Next slide, please. This we have already discussed. Next slide, please. So there were some key subgroups which were studied. So EGFR positive patients after EGFR TKIs. In this subset of patients, next slide, please. So total population was 1,202, and in these the 160 patients had EGFR mutation or ALK rearrangement, and the EGFR mutation was seen in 124 patients, and sensitizing mutation was 91. So next slide, please. This also includes the population with prior this EGFR TKIs. So PFS benefit was observed in the patient whoever EGFR mutated patient, and hazard ratio of 0.59. So and this PFS curve started separating at 6 months. Next slide, please.
Dr. Parvesh, I would request you to wind up in next 1 or 2 minutes, please.
Okay, sure. This overall survival benefit persisted in EGFR mutations, those who were treated with previous TKIs. Next slide, please. This was again the similar. Next slide, please. This also showed that the overall response and duration of response were better in these EGFR mutated patients. Next slide, please. This one subgroup is liver metastasis. Next slide, please. If the patients were stratified according to the next slide, please. Next. Next slide, please. The patient with bulky disease also had a very good response. Next slide, please. The patient were stratified according to high disease burden and based on the sum of longest diameters and on the basis of number of sites. So next slide, please. Both of these group of patients, when stratified according to these two subsets, had a very good response and response rate as well as survival benefit with this combination. Next slide, please. Next. This data support that the use of atezolizumab plus bevacizumab persisted in high risk subgroups, and adverse effects were as the previous noted with atezolizumab, bevacizumab, and this chemotherapy combination. Next slide, please. I think that is all. Thank you, sir.
Thank you, Dr. Parvez, for a wonderful talk. I can see one or two questions in the chat box, so I would request you to answer these.
Yes, sir.
One question that has popped up is role of metronomics in the current scenario, especially for financially constrained patients. So what is your thought and what is your take on this?
Financially constrained patients, though there are no clear-cut trials in lung cancer for this metronomic chemotherapy, so the better would be a combination of combination chemotherapy or individual chemotherapy agents which were not used previously can be used.
Thank you. And the second question is it possible to give atezolizumab, bevacizumab, carboplatin, and nab-paclitaxel in patients with hemoptysis?
Hemoptysis.
Yes.
We have to see the cause of hemoptysis. What was the cause of? If the cause is of like this some aneurysm or any vessel involvement is there, then better we should avoid. If other than that some cause is there which is correctable, after rectifying the cause we can give this combination.
Thank you, Dr. Parvez, for your wonderful talk and your insights on this topic. So moving on to the next slide, next topic. It is a talk on the ALK positive lung cancer, and I would be talking on the topic. So the topic is sponsored by Pfizer Oncology, and the topic is a new benchmark in the first line management of ALK rearranged non-small cell lung cancer. Are my slides visible?
Sir, please make it fully screen.
Should I start?
Yes, sir.
So this is the development of the ALK, inhibitors that we all are aware of. So this is the timeline that we all see very routinely in our practice. So discovery of EML for ALK translocation in 2007, crizotinib, the first generation molecule in 2012, then ceritinib 2015, then third generation lorlatinib 2019, and then US FDA lorlatinib approval for the first line in 2021. So there has always been an unmet need in the ALK positive lung cancer because it is generally seen in young population, non-smokers, light smokers. There is a high incidence of CNS metastasis. There are ALK resistance mutations. CNS metastasis is very common. There is inadequate penetration of the drugs which are available. And 1 in 3 patients, they do not receive second-line treatment despite developments of second-generation drugs, either due to the performance status or cost or availability. So we have to be very, very watchful for the overall efficacy, for the overall survival, for the CNS activity, for the response rate, for the progression-free survival. So we have to hit hard. We have to hit hard the first way, and then there are always these parameters that we have to keep in mind. So this is the CROWN trial. This was the crown of the ASCO plenary session this year because this was the lorlatinib phase 3 trial which was shown. It was stage 3B for ALK positive patients, first line, asymptomatic treated or untreated CNS mets, randomized to lorlatinib 100 milligrams versus crizotinib 250 milligrams BID, and the primary endpoint was progression-free survival. And what was the planned interim analysis in efficacy-wise, we could see there was a huge difference in the PFS. The PFS was 78% versus 39%, and the PFS by investigators was 80% versus 35%. And look at the hazard ratio. It is 0.21. it is very, very rare in oncology to see such early separation of curves. It is very rare in oncology to have a hazard ratio of 0.21 and see how distant these curves are. So coming to the 5-year efficacy analysis, again, you see these curves, they separate very, very early, and this separation continues to be there at the end of 20 months, 36 months, 48 months, and see the hazard ratio again, it is 0.19. So after 5 years of follow-up also, the median PFS with lorlatinib treatment has not been reached, and an investigator PFS assessed rate of 60%. So this is unheard in oncology. Now, patients with and without brain metastasis, patients who had a baseline brain metastasis, we could see here that the PFS is again not reached versus 6 months. And patients without baseline brain mets, it is not reached versus 10.8 months. And the hazard ratio in CNS metastasis is 0.08. And in baseline no brain metastasis is 0.24. So median PFS, it is not reached versus 9.1 months. And in LX, that is the alectinib versus crizotinib arm, though it is not a direct comparison, it is an indirect comparison, but it is 34.8 months versus 10.9 months. So CROWN, it also showed that lorlatinib delayed the intracranial progression versus crizotinib. There was no intracranial progression events even after 3 years, that is 36 months. And the hazard ratio is 0.06. So time to IC progression by investigator assessment in patients with and around metastasis, it understood that lorlatinib delayed the CNS progression in patients with existing brain metastasis, and it delayed the onset of CNS disease in patients without baseline brain metastasis. So it is effective both ways. So as I previously mentioned, that it is not a direct comparison, but if we see lorlatinib and crizotinib versus alectinib and crizotinib, what we see here is that patients with brain metastasis, lorlatinib appears to be the most effective drug available as of today. So again, it is in the terms of the progression-free survival also, it is patients with and without brain metastasis that lorlatinib appears to do fine. So in patients with baseline brain metastasis, lorlatinib resulted in high intracranial responses, and the majority of them were complete responders. And if you see the percentage of complete intracranial responses in lorlatinib arm, it was 57, that is 38% of these patients, while as crizotinib had none. Now coming to the subgroup analysis, it again shows that patients who had a median PFS in poor prognostic group V3 was 60 months, demonstrating that lorlatinib activity across all variants of EML4-ALK. So it is not only effective in variant 1 and 2, but it is also effective in variant 3A and B, which are considered to be the bad prognostic subgroups. And here also the median PFS for variant 3 in the LX trial with alectinib was 17.7 months, which was far less than what we see with lorlatinib. Now, if you see the efficacy by the TP53 status in patients with baseline ctDNA, here also the patients who had TP53 mutations, the median PFS was 51.6 months, demonstrating that lorlatinib activity in difficult to treat populations was much more better than its comparator arm, that is crizotinib. So what are the resistance patterns after ALK TKIs? We all know that resistance to second generation ALK TKIs, it is largely driven by secondary ALK kinase domain mutations, particularly G120, 1202R. And it is, we see here all these, driver mutations, which are a resistant mechanism that are happening after the second generation TKIs. So as more generations of ALK TKIs were sequenced, there were more monster ALK resistance mechanisms that developed. And with each line of treatment, more resistant and more difficult clones of ALK mutations, they come up. So lorlatinib, it suppresses the emergence of single ALK resistance mutations. So upfront lorlatinib could significantly delay or suppress on-target resistance mechanisms. And this could play a very important role in the whole paradigm of ALK positive lung cancer. So it is a summary of the potential resistance mechanisms against lorlatinib or crizotinib. If you see the resistance mutations, which new single mutations on lorlatinib were none versus 6 on crizotinib. ALK compound mutations were found to be none in comparison to 2 on crizotinib, and bypass mechanisms were less in lorlatinib comparison to crizotinib. So this is the the safety profile of lorlatinib. If we see the adverse events, we will come to know that adverse events with lorlatinib are largely manageable with concomitant therapies, temporary treatment interruptions, and dose reductions. And if we manage this drug well, many patients would actually have advantage with this wonderful drug. Now, what are the summary of adverse events? Adverse events leading to dose reduction in the CROWN trial with lorlatinib, they were 23. With alectinib, it was 20.4, and crizotinib range between 15 to 20. And if we see the adverse events which were leading to treatment discontinuations, it was actually less with lorlatinib in comparison to alectinib in ALEX trial, where there were 11 events and there were 114.5 events. So the most common grade 3 and grade 4 adverse events in the lorlatinib treated group were hypertriglyceridemia, ranging to around 25%, increased weight around 22%, hypertension, and hypercholesterolemia. So hyperlipidemia in CROWN trial and hypertriglyceridemia, they are the common side effects, and all grade side effects range between 60 to 70%, and grade 3 and 4 to the range of 20 to 25%. So the frequency and severity of the CNS adverse events were in line with the prior analysis, and no new adverse events were noted in the safety population. So we have to be watchful for hyperlipidemia. 72% of the patients, they experience this, as already mentioned. CNS events such as mood, cognition, speech, and psychosis were experienced, and edema and weight gain, they also are common with this class of side effects. So what is the 5-year safety summary? Lorlatinib safety profile was consistent with that in the primary analysis. No new safety signals emerged at 5 years. Only 5% of the patients, they discontinued lorlatinib, and dose reductions did not compromise the systemic or the intracranial efficacy of lorlatinib. Now, coming to the therapy management, we have to be watchful of hyperlipidemia in the first month, edema in the second month, usually mood effects by second month, psychotic effects by second month, peripheral neuropathy and weight gain by 4th or 5th month, and cognitive effects by 6 months. So it can be the adverse events, they can be managed with a 4-step approach. We have to be preparing the patient. We have to monitor for these side effects. We have to manage them, and then we have to continuously reassess these side effects. So how do we manage? We baseline measure the lipid levels. Then if they found to be increased, then we either add anti-lipid lowering therapies, or if anti-lower lipid therapies are used and still they are not in control, then we lower the lorlatinib dose by 25 milligrams. So similarly, the weight gain, again, we have to do the lifestyle modification and toxicity management. If it improves, okay. Otherwise, we have to sometimes reduce the dose or interrupt the dose. Similarly, edema, peripheral neuropathy, and CNS side effects have to be maintained and managed. So this is the indirect evidence of what we are talking. And here also we come to see that lorlatinib actually is the most effective therapy when used frontline for patients with ALK positive lung cancer. The NCCN guidelines, it's a category 1 recommendation. And with this, I stop and I tell that lorlatinib has a very, very effective role in ALK positive lung cancer, and especially those patients who are having a CNS disease at baseline. Thank you. So moving on to the next session is a panel discussion on driver mutation positive metastatic lung cancer. And I would welcome Dr. Trivikram Rao, medical oncologist from American Oncology Institute, Hisar, and panelists Mubin Mittal, senior consultant medical oncologist from Patiala, Dr. Rajit Ratan, my colleague from Ojas Hospital, Panchkula, and Dr. Navdeep Singh, medical oncologist from Deep Hospital, Ludhiana.
Dr. Trivikram Rao is not available. He just informed me.
Oh, okay. So in that scenario, let me see And if I can ask a few questions to my panelists. Are my panelists there? I would welcome Dr. Mubin, Dr. Rajit, and Dr. Navdeep.
Dr. Rajit and Dr. Navdeep Singh are there.
So let me then go through the
Sir, can I present slides?
Just a moment. Let me have just one moment. So Dr. Trivikram Rao was supposed to do a panel discussion on this, which are the slides visible now?
Yes, sir. Visible.
Okay. So if this is visible, then we will have a short discussion on the, driver mutation positive non-small cell lung cancer. And these are the points to discuss. Testing for driver mutations, complex case scenarios, role of molecular tumor board, and the targeted therapy. Coming to case number 1. So 2021, a metastatic CA right lung with baseline bone and brain mets. Histopathology, adenocarcinoma lung TTF1 positive. Found to have EGFR exon 9 detection by RT-PCR May 2021 and ALK by IHC negative. So coming to my panelists, will you plan treatment with this information or do you ask for some additional testing? Anybody can take this question.
Hello. Am I audible, sir?
Yes.
So just I want to know how number of the brain mets. Otherwise, I would like to start treatment in this patient, sir.
So you would like to start the treatment for this patient. You would be requiring the information on brain mets.
I just want to know.
Sir, whether the patient is symptomatic for brain mets, then we can go for WBRT.
So let us consider both these scenarios. So one, the patient is symptomatic, and one, the patient is asymptomatic. So how your approach would different and how the treatment would be decided on this? Dr. Mubin?
Sir, suppose patient is asymptomatic and depending on the number of mets, if the total volume of the number of mets is less than 12 cc, and we can directly start with the anti-EGFR therapy. That is depending on the cost. If the patient cost doesn't have any issue, then definitely osimertinib is the treatment of choice with maximum PFS. And if the patient having some cost issue, then definitely we can start with the erlotinib.
Okay, so everybody would start with osimertinib, or there would be some difference of opinion, Dr. Navdeep?
Yes, I would like to consider osimertinib in this patient, but I would definitely want to highlight the recent data of Mariposa, in which it was a good trial in which osimertinib has been compared with amivantamab and lazertinib, which is a third generation TKI. The PFS benefit was more with the combination compared to this osimertinib. Although it's not FDA approved, but I would definitely, if it is available, would like to consider.
So how many patients, do an NGS for, you do NGS for everyone? Or like here you do an RT-PCR followed by an IHC. What is your modality of, investigation once a new patient is being diagnosed with lung cancer in your practice?
Sir, I definitely recommend some broad panel testing, RNA and DNA based NGS. I think we should do in all lung cancer patients, the testing should be NGS based. Preferably, I would be doing NGS based testings.
Dr. Rajit, in your practice, how many of your patients actually end up taking osimertinib in first line?
I think somewhere around 10-20% is my ballpark figure if they are not reimbursed by a government agency. But yeah, that's pretty much it.
So at least we all agree that practically osimertinib, due to the cost issue, is not a very common drug that every person can afford. So suppose osimertinib is out of picture, then what would be the line of treatment that you would, adopt in such line of patients?
I think there is merit in starting chemotherapy with geftinib that had shown a good OS benefit. The Tata trial I'm talking about. But then you have to see if your patient will be able to tolerate the combination or not. There are side effects associated with it. But that remains a viable option. Combination of TKI with chemotherapy.
Okay. So, Dr. Navdeep, will you choose afatinib or will you choose chemo plus geftinib?
Sir, I think I would choose afatinib in this patient. I think chemo is also an effective option, but if possible, I would go with only oral drug, afatinib, sir.
Dr. Mubin, your take on this?
So depending on the performance status of the patient, and if the patient is definitely patient will be a old patient with the definitely lung complication with COPD, a patient there is I think there is no history of smoking. I will go with the TKIs. If the performance status is good, then definitely we can think of chemotherapy plus TKI.
Okay. And anybody would be interested to use if a patient is fit and affordability is not a concern in first line ABCP?
No.
So this is the NGS report that is there on the screen. It has tier 1 pathogenic, mutation with exon 19, and there is also a likely pathogenic missense mutation in exon 6 of TP53, which is likely pathogenic. So TP53, how do you take this report as? What is the clinical significance or inference when you see this report like this in your day-to-day practice, Dr. Navdeep?
So I have not seen such case, but I think these patient will definitely behave a little bit aggressively. Treatment point of view, I might not change much, but definitely these patients will behave aggressively, sir.
So correct, as we have already mentioned, the options are in front of us. One of the options is osimertinib or second or first generation TKIs. The other would be FLAURA2 or erlotinib plus anti-VEGF. So depending on multitude of factors, performance status, cost, CNS disease, we would take a call depending on what we actually end up doing for our patients. So coming to a second case of 54-year-old lady, non-smoker, metastatic lung cancer, adenocarcinoma, NGS shows exon 21 L858R mutation. So for such a patient who has exon 21 mutation, will you treat this case in 1 and 2 differently, or for you, these both cases are same?
Sir, for me, I think these
Dr.
patients.
Rajit?
Hello.
Yeah, Dr. Navdeep, sorry, please continue.
Sorry.
Sir, I think in FLAURA, these group of patients, the L858R, these patients didn't benefit much with the osimertinib compared to exon 19. So again, with this recent data of Mariposa, we have some group of patients which don't respond very well to osimertinib. So maybe I would like to consider some other therapeutic options.
Correct. So one, these are inherently not very responsive, and also there would be some impact on the co-occurring mutations, as I mentioned. But it is very difficult to actually have an assessment of what impact these co-occurring mutations would have on the response of the therapies that we intend to give. So, which co-mutations do you consider significant while planning a treatment? So again, TP53 is one of them, where bad prognostic part would always be there when we see these mutations associated with the patients. So what would be your preferred first-line systemic therapy option for a patient who has a TP53 mutation in addition to adenocarcinoma, EGFR? Dr. Navdeep?
Sir, I would like to add chemotherapy to osimertinib, sir.
Could be. So that could be one option. So moving on to the, a few questions on EML for ALK fusion variants. So when you see the ALK positivity in your reports, does the variant matter? Or do you look for specific variants on your report, or ALK positivity means ALK positivity for all your patients?
So right now, I just look for ALK positivity if it comes, sir.
Dr. Mubin?
Sir, definitely. But if the ALK mutation is positive, then definitely we can look for other variants also. They have significance also. Whether the patient is to be started on the lectinib, lorlatinib, because certain mutations are resistant to the first line or second line ALK anti-ALK therapies, and lorlatinib is effective against almost all the ALK variants.
Okay, so I think for us, for all practical purposes, ALK positivity, which in itself is a rare phenomena, ALK positivity means ALK positivity. Though variants are associated with poorer prognosis, but we tend to give the best anti-ALK positive anti-ALK therapy at the first line.
Yes.
So,
hello, Chitresh. Can I
Dr.
speak?
Jagdeep, please. Yes.
So that's true that ALK is not very common, but still, if you ask me, so we have to go with the ALK ML4 positivity. It is the best which will give the result with us. So there are some 6-7 types of fusions which we used to see with the ALK. So, but according to me, I will definitely go for the partner with which it is going. And if I don't see that any other drugs, because I'm not sure at this point of time, but I had one discussion at somewhere. So EML will be the best to give the outcomes with the ALK inhibitors.
Correct, sir. But also we have to, in EML, ALK4, we have to see for the variants like variant 1, variant 2, variant 3. So what I wanted to say was that variants 1, 2, and 3, variant 3 is associated with a bad prognosis. And so irrespective of the variants, we still end up choosing the best anti-ALK therapy that is available.
So the other thing is that we don't have other options for other variants. So that's why we are choosing this.
So we don't know whether anything else would be available to us or not, but at the right time, lorlatinib or drugs like that would be effective. So suppose these patients progress, on any therapy that you gave on first line, do you rebiopsy? And if biopsy is not possible, how many times you end up doing a liquid biopsy in this particular setting? Dr. Mubin, Dr. Navdeep, anybody can answer.
Sir, when the patient is started on the lorlatinib first line and on progression, patient is to be rebiopsed or liquid biopsy. It depend for the T790M mutation. To start with, if the mutation is positive, then we have to start patient on the osimertinib. And better to have the biopsy. In case of liquid biopsy, sensitivity is only 60%. That is the major drawback of liquid biopsy.
Dr. Navdeep, your thoughts?
Yes, again, we have to change the line of treatment. But yes, problem with the liquid biopsy is, again, as Dr. Mubin told, sensitivity less and PDL1 testing if it needed. It can't be done.
Dr. Jagdeep, what do you do in your practice?
So, Chitresh, ideally, patients are not willing for the rebiopsy. Honestly, nobody is willing. And even if you are planning for a rebiopsy, it should be ideally done from the progressive side.
New side or a metastatic side which has come up.
So if the patient is still not willing for that, I might suggest a liquid biopsy, but I don't know. Means 2/3 of the patient, they are not there. Means 2/3 of the concordance is there. Rest you can see not there. So rest means 1/3 patient can be concordant with the liquid biopsy as with what. So usually I don't do, and I don't advocate, but if the patient is willing, I will definitely.
So Dr. Rajit, do you end up choosing your treatments or changing treatments based on what liquid biopsy report tells you in this setting?
Sir, if it is positive, then definitely yes. But if it is negative, then I will have to sort of again go to the drawing board and see whether it is false negative or it is like really negative, because the sensitivity issues will always remain with a blood-based assay.
Okay, so I think because your primary moderator was not there and in want of time, we would stop. Dr. Jagdeep has joined us for the last talk. So I would request Dr. Jagdeep to please, give his talk on immunotherapy in non-small cell lung cancer. Welcome, Dr. Jagdeep. Thank you for agreeing to do this.
Thank you,
And
Chitresh. Always
welcome.
nice to see you whenever
Thank
you're there, either physically or in webinar. So thank you, Chitresh, for all this. So I'll just sharing my slides. So are my slides visible?
Yes, sir, visible. Please
Yes,
take
sir,
it.
but you have to,
So-
this full screen.
Yes, is this okay now?
Yes, sir. Yes, sir.
So thank you. Thank you so much. Thank you, Chitresh and Team Horizon for organizing this event. So my job is to optimize use of neoadjuvant immunotherapy in non-small cell lung cancer. So we started from the metastatic setting, we went up to the adjuvant setting, and now we are in the NACT. So there is always a transformation of the line of the treatment in the patients. But of course, the drugs which have been tried initially were majority in the metastatic settings. So this is just showing that we are now into the neoadjuvant setting with the chemotherapy along with the pembrolizumab or the nivolumab or the ipilimumab. These were the different settings. So this first study of Checkmate 8116, this is a phase 3 trial, and of course, non-small cell lung cancer with the stage 1B, 2, or 3A. The PDL1 scoring more than 1 or less than 1%, and patient, they were randomized either to nivo plus chemotherapy every 3 weekly or chemotherapy 3 weekly. So patient underwent surgery within 6 weeks of the completion, and later on, they received adjuvant optional CTRT and follow-up. And the primary endpoint was complete pathological response and event-free survival. And the secondary was, of course, the overall survival and the major pathological response. So if you see the patient who received this nivo plus chemotherapy, they tend to do better as compared to the patient who received only the chemotherapy alone. And the complete pathological responses were close to 24% of the patient who received this combination as compared to 2.2% in patient with the chemotherapy alone. So if you see in the graph, all the bars are favoring the nivo plus chemotherapy arm as compared to the patient who received the chemotherapy alone. So of course, if you see in the PDL1 scoring, if you go more than that is 1%, the patient, they tend to do better as compared to less than 1%. So, and again, the tumor mutation burden, if the patient have higher burden, they have more chances that they will get a better response. And of course, the stage either 1B, 2 or 3A in total, that's shown benefit. But particularly in categorically, if you see through the details of this trial, the stage 3A is much more benefited as compared to the stage 1B. So the event-free survival was approximately 21.1 months in the patient who received chemotherapy versus it was not reached in the patient who received the nivo plus chemotherapy. Again, the OS data, it was not reached on both sides. And if you see in accordance with the pathological response, the patient who received the nivo plus chemo, they tend to do better as compared to the patient who received who did not have a pathological response. So even though they have received this chemotherapy plus nivo, but who achieve a PCR, they tend to do better as compared to a patient who are without PCR. Similarly, the patient with the chemotherapy, who achieve PCR, they have a better event-free survival as compared to the patient who did not achieve the complete pathological response. So in accordance with the major pathological response, it again follows the same track. That patient who has achieved pathological response, again, it was a better, that is major pathological, that is less than 10% of the viable tumor. It was more better in the patient who received the PCR as compared to the patient who did not receive this PCR in both subsets, that is whether nivo plus chemo or chemotherapy alone. So to conclude with this Checkmate 816 trial, there's a post-hoc analysis of this which showed that PCR or MPR is the primary tumor which was associated with the improved EFS with the neoadjuvant chemo plus nivo and chemotherapy in resectable non-small cell lung cancer. In the nivo plus chemo arm, the EFS improved in patient who had a PCR regardless of the baseline staging or the PDL1 expression, and the depth of this pathological regression with the neoadjuvant nivolumab and chemo may be predictive of the 2-year EFS. And NACT with the chemo plus immo showed a similar safety profile in patient with or without PCR or MPR and was consistent and was treated with all the patient. And it was concluded that these results support pathological response as an early indicator of the event-free survival benefit in the patient receiving a neoadjuvant chemo plus immunotherapy. So next trial for the neoadjuvant was the pembrolizumab, and in this you can see that trial 611. The background was that PD-L1 inhibitor are standard of care for patients with advanced and metastatic, which I just stated earlier, and they have demonstrated benefit when administered before the surgery. And there were some other phase 3 trials, that is AGN trial and NeoTalk trial, that is of topiramab and durvalumab, which showed significant EFS benefit with the perioperative approach that includes this neoadjuvant and adjuvant PD-L1 or PD-1 inhibitors. And in this phase 3 trial 671, which were designed to evaluate the perioperative pembrolizumab plus chemotherapy in patients with the early stage non-small cell lung cancer. So again, this was a phase 3 trial. Again, stratification was done based on the stage, TPS scoring, histology, and of course the geographic distribution. And the randomization was done in the patient with the pembrolizumab plus chemotherapy up to 4 cycles every 3 weekly, or otherwise placebo along with the chemotherapy every 3 weekly for 4 cycles. And then patient underwent a surgery, and then they received the adjuvant pembrolizumab in the pembro arm versus placebo in the chemotherapy arm. So primary endpoint was the event-free survival, and secondary was the major pathological response, safety, and PCR as per the blinded independent pathological review committee. So patient screened were approximately 1,300, and approximately 400 patients were randomized in each arm, and approximately 74% in the each arm completed 4 cycles of this either pembrolizumab or placebo, and in those 87% in each group completed more than 3 cycles, and approximately 13% in the pembro and 16% in the placebo, they considered all study treatment permanently. And approximately 82% patient in the pembro arm and 80% patient in the placebo, they underwent surgery. And close to 8% patient in the pembro, they received the adjuvant radiotherapy versus 13% in the placebo arm. So again, if you see adjuvant therapy was given in the patient or the pembro, that is 73% versus 66.9%. And approximately 40% in the patient in the pembro, they completed the adjuvant treatment as compared to 35% in the placebo arm. So the baseline characteristics was well matched in both sides in considering of the median age, gender, race or geographic region or performance status, and histology and current smoking or former smokers, stage, and of course the PD-L1 and the nodal status. So again, the patient who underwent surgery, if you see in patient who received the pembrolizumab, approximately 97% in both arms, either in pembro, placebo, they underwent surgery. And patient in the pembro arm, if you see, complete resection was achieved in 92% versus 84% in the placebo arm. And patient who received pembrolizumab, approximately 78% went lobectomy. While if you see in placebo, it was slightly higher for the pneumonectomy, that is 12% versus 11%. And approximately the 30-day all-cause mortality were similar in the both sides. Again, the event-free survival was not reached in the patient who were receiving this pembrolizumab as compared to the placebo, which was 17 months. And again, if you see this subgroup analysis, the patient who received this pembro, they tend to do better as compared to the patient who received the placebo, either considering any of the characteristic features, that is age, gender, race, smoking status, histology, or PD-L1 status overall. And even the patient who had an EGFR mutation, even they tend to do better as compared to the patient who were not aware of this EGFR mutation status. So again, the overall survival point in these patients were not reached in a patient who were receiving the pembrolizumab arm as compared to the placebo, which was 45.5 months. So with a hazard ratio of 0.73, it showed that patient who received this pembrolizumab arm, the risk of progression to that was approximately less than by 27% in the patient who received this placebo. Again, the important thing is the pathological response by the blinded independent pathological review committee. Patient who received this pembro arm, they had 18% versus 4% with the placebo. And major pathological response was seen in 30% patient who received the pembrolizumab arm as compared to 11% in the placebo arm. So exploratory analysis, again, with the PCR status, patient either who received this pembro or without PCR, with PCR, they tend to do better. Again, with the major pathological response, patient who received pembro, they have either received MPR or without MPR, or placebo with MPR or without MPR. The patient who received the pembro, they tend to do better as compared to the patient who received the placebo. And treatment of exposure and adverse events were approximately similar in both sides. No such significant difference was seen. And again, this was the any cause treatment-related adverse events which are seen across the patient in the. So to conclude, the patient with the resectable stage 2, 3A, 3B, this NSCT with the pembrolizumab plus chemotherapy followed by surgery and adjuvant pembrolizumab was associated with a significant improvement in the EFS as compared to the chemotherapy or surgery alone. And median EFS was not reached in the pembro arm as compared to the placebo, which was 17 months. And overall survival difference was not significant different in this analysis, and it will continue to be tested. And this perioperative pembro was associated with significant improvement in the pathological response rates. Though this exploratory analysis suggested the benefit with pembro, regardless of whether patient attained this PCR or MPR, and safety profile were as expected based on the individual agents. And this investigate concluded that these findings support this perioperative chemotherapy with the pembro as a promising new treatment option for the patient with a resectable stage 2 or 3 non-small cell lung cancer. So this is another trial for the perioperative chemotherapy, that's NeoTalk. And in this patient who received this toripalimab plus chemotherapy as compared to placebo plus chemotherapy with untreated resectable stage 2 or 3 non-small lung cancer. And the current pre-specified interim analysis of this event-free survival in patient with a stage 3 cancer was previously presented in an April ASCO plenary session. So again, this was a phase 3 trial. Patients were again randomized according to stage and according to surgery or the histology or the PD-L1 expression. And patient was randomized to again toripalimab and chemotherapy platinum based and placebo plus platinum. And following surgery, patient received the adjuvant toripalimab and placebo in the other group. So primary event-free survival was the primary endpoint, and secondary endpoint was the overall survival, and again the complete pathological response rate in this patient. So again, the baseline characteristic was well matched in the patient who was receiving this toripalimab or placebo in the form of the age or smoking status or gender or the histology or the clinical staging. So if you see the treatment summary, the patient who received this drug, approximately 17% of the patient did not underwent surgery. And in this patient who received placebo, this number was quite high, that 26%. So again, the patient with a progressive disease was 15% in the placebo arm. And the surgery was approximately 82% performed in those patients who received this toripalimab as compared to the placebo. So again, the surgery lobectomy was on the higher side in the patient who received this placebo, and sleeve lumpectomy or other things, lumpectomy, they were again slightly higher in the patient who received this placebo. So to see the primary endpoints, the patient who received this toripalimab, the median EFS was not reached in those or not estimated as compared to the placebo, which was 15.1 months. And again, the major pathological response was 48% in the toripalimab as compared to 8.4% in the patient with the placebo. So with a significant difference of the 40%. So as we have seen, the patient who received a good pathological response or major pathological response, they tend to do better as in the previous with the pembro or the nivi. So similarly, it followed the same rule in the patient who received this toripalimab. That patient who had a good pathological response or major pathological response, they tend to do better. So secondary endpoints, again, patient who achieved this toripalimab, PCR was 24.8% as compared to the placebo, that's only just 1%, and a significant difference of 23%. And median EFS by the independent review committee was not estimated in the toripalimab as compared to 15 months with the placebo. And again, the 1 year overall survival rate was 94% with the toripalimab as compared to 89% the placebo, and 2 year OS rate was 81% versus 74%. So these are the safety news, no new safety signal as we take into account of the immunotherapy along with the chemotherapy. So approximately they were almost similar in both groups. So to conclude, the interim analysis of this phase 3 NeoTalk trial of the patients with the stage 3 LC found that addition of this toripalimab to the chemotherapy resulted in significant improvement in the event-free survival and the higher visual pathological response and complete pathological response. And this EFS was consistent along all the subgroups, irrespective of the PD-L1 status, that is less than 1% or more than 1, and or even in the histology, that is squamous versus non-squamous. So it was concluded that in NeoTORC and other trials published a standard of care for the stage 3 NCLC as a perioperative immunotherapy plus chemotherapy. So this is again a perioperative chemo regimen for the durvalumab agent trial, phase 3 trial. Again, patient received a durvalumab in the neoadjuvant versus a placebo and underwent surgery, and again 12 cycles of adjuvant durvalumab. So similarly, PCR was again one of the primary endpoint in this, but the secondary was the MPR, again OS in the secondary endpoint. So this is a trial which showed the patient who received this durvalumab, the median event-free survival was not reached as compared to 25.9 months in the placebo arm. And again, all the subgroup analysis showed that patient who received the durvalumab, they tend to do better as compared to the single agent chemotherapy. And patient who received durvalumab, the PCR was close to 17.2% versus 4.3%. So to conclude, all the trials, whether Keynote 671 or AGN or NeoTORC, they all showed the patient who received the neoadjuvant immunotherapy plus chemotherapy, followed by either adjuvant therapy or optional treatment in the form of CTRT, they tend to do better as compared to the patient who do not receive this neoadjuvant immunotherapy along with the chemotherapy. So now neoadjuvant chemotherapy is a standard of care in stage 1B, 2 or 3A bar 3B in a patient with a resectable non-small cell lung cancer. Thanks for your patience listening.
Thank you, Dr. Jagdeep, sir. Thank you for a wonderful talk. And as you showed rightly that in lung cancer, I think every setting immunotherapy has taken over. So
Yes.
whether it is neoadjuvant, adjuvant, metastatic, everywhere, I think immunotherapy has one of the robust evidence in role. So I
Yes.
thank you for your wonderful talk, and
Thank
thank you for joining. Thanks a lot.
Thank you, Chitresh.
Thank you, sir. Thank you. So with this, on day one, I think the agenda for day one is complete. Today we could see the evidence in breast cancer and lung cancer. And I thank all the participants, all the moderators, all the discussants to play a very active role in day one's discussion. Over to Horizon Conference Management, guys. Thank you.
Thank you, sir. Thank you, everyone. Good night. We will meet next day. Thank you.
Hello, sir. Can I close the session?
Wait 2 minutes.
Okay, sir.
Technical team, now you can close the meeting.